This conference will now be recorded.
everyone.
Right. Okay. It's a fun. I have been talking for about last 10 minutes without putting my mic on. Yes, I have put the mic on now. Nawal, Sundar, everybody, yes. Are you able to hear me now?
Yes, very much, Dr. Safiya.
Right, okay. My apologies. Actually, I have been talking for last 10 minutes without putting mic on. Anyway, so I'll start again. So clinical governance is the session today we're going to do. I am recording this, so you will all have the recordings of this session. Just to go over afterwards. It's going to be lengthy and maybe a bit complex session today, but don't be stressed. You know, as I said, like you will have the recordings and then when you sit till exam, you have the opportunity to ask the queries and we will go through those. So what I have done today, we will be discuss about the clinical audit. Then we're going to discuss about the risk management. Then I have consent, maternity dashboard. So these four are mainly under the umbrella of clinical governance. Then we're going to do one station on MDT referral, how we complete MDT referral and what exactly happens in MDT meetings and how the plan come back from MDT meetings. So that will be done. Then we have one station on OSATs sign off. What is the prerequisites of summative or formative OSATs and how they can be done and what happens if the trainee basically have a conflict with us. Maybe we don't want to sign up, but the trainee is adamant that she should be signed up, then how we deal with that situation. That is the part of this one as well. Then we have one station on clinical reflection, where the scenario I put is one of ST2's want to, you know, reflect on one of his patients she has managed. Then we will be doing one station on bullying, undermining of your colleague as well. And in addition to that, we will also do, so these are the mainly planned for today, but we will see how we go, how the time goes. Then I will also include, and we will cover situations on prophylaxis, bridging prophylaxis. Somebody posted me, well, a few people have actually posted me requesting we would like to do that. So we will be doing on that as well. Then there have been few I just added to remind me at the end what they were. Yeah, and how we write the operation notes, how to give the feedback and operation notes, GP discharge letter. We will also do how you develop enhanced recovery pathway, early enhanced recovery pathway, and what are modified early warning sign shouting and monitoring. But these last four ones we will be doing in one of our future sessions. So there are two sessions. One will be on 14th of March and one will be on 15th of March. In these two sessions, one session will be for structured discussions. So our previous recalls, most of the previous recalls on structured discussion. And then one of the sessions we will be using for a few of these things, which we talked about. Right, so so I posted the clinical audit video to all of you to watch. I hope most of you would have done that. And the people who have done that, obviously, will be quite easy for them actually to overgo now and understand. The people who could not have the chance to go through that, don't worry. Even if you find it, it's not going to be complex. You will find it really easy from today onward. But if you find it still is a bit tricky, just ask me later on, okay? There is still enough time for us to just keep going over things. Right, so clinical audit is the first one. So what mainly is clinical governance in a very simple and understandable words? Clinical audit, clinical risk management, or incidence reporting, consent, maternity dashboard. These are few the tools which are used. Overall, they are called clinical governance. Clinical governance basically is just the process, you can say, or you can say some protocols or some pathways by which all NHS services basically monitor and assess their quality and safety of the care they are providing, which can be clinical care as well as the care towards their staff, as well as regarding the building and all those matters. So by these tools, we are supposed to compare our performance against the national defined standards to make sure that all the services overall in the country, they are performing the same standards of care and quality to the patient, irrespective whether they are located at small places or in the big cities. So that is the main purpose for these clinical audit and stuff. So what is clinical audit? Now, clinical audit is again one of these quality improvement or quality monitoring process with which we actually assess the quality and effectiveness and safety of care we provide to our patients. Okay. And it can be like different. So you can do the clinical audit on your clinical situations, like management of the diseases, other situations like management of shoulder dystocia, APH, BPH, all of them. And sometimes it can be even on the non-clinical matters as well, on the organizations, like number of staffing, and how much staff is actually safe, and for how many number of patients. These type of, they all can be done by clinical audit as well. And they are defined, there are certain defined standards at national level. So if we come back to the clinical practice again, so we know the national standards defined for any particular conditions, treatment, and the management, how it should be done. They are defined in our guidelines. Yeah. So the national standards for us for clinical is, they are mainly our guidelines. So you have for obstetrics and gynecology, we do have our green top guidelines. You got your blue top guidelines like good practice guidelines, NICE guidelines, and scientific impact papers. So scientific impact papers are not quite the standards. They are research and then recommendations. So it will be good practice guidelines and green top and NICE guidelines, basically, which we will be using as a tool, as standards to compare our performance. Okay. So that's what I have just written over here. Now, clinical audit is a very simple and straightforward procedure. There are 6 stages of this, right? So now you all can take the picture of the screen, because whenever you are to deal with the audit scenario, you need to fit in your things under these 6 headings. Okay. So the first one is identify the problem, what we want to audit and why. Now, when we do the audit of any clinical condition or practice, that doesn't necessarily mean that something is going wrong with that and we are not doing well, and that's why we need to do the audit on this. Most of the time it is, but then sometimes we also do, not sometimes, we always do the audit on some new recommendations as well. So for example, when the guideline changes, some new guidelines come into, which actually suggest some changes in the previous treatment or whatever the way we are managing that particular condition. So then there is a certain time period in which every unit will tell to their unit that this guideline will come in effect as per this date. And then after 6 months or 1 year from the date when we actually applied that guideline in our service, then we do the audit. Simply, we just measure to see how much actually we are doing according to that guideline. Okay, so it can be either something which is going wrong, or even sometime when there is some new guideline applied, and sometimes you just routinely do it because it's not like, say for example, management of pelvic inflammatory disease. So there was a guideline to start with. Okay, we then did, that we applied that guideline, and then after 1 year we did an audit on that to see whether we were actually doing according to those guidelines. You completed the audit, and then apparently everything is going fine, but 3-4 years down the line, then we feel like it's been 3-4 years, we haven't particularly seen back to our management of the pelvic inflammatory disease, that all the clinicians are still actually. So you might just pick up the topic again after 5 years or 6 years time to say, let's just measure it again to make sure we are still actually adhering to the national guideline. So that's the second way you pick up. And the third most commonly used point of the source to choose your topic basically for the clinical audit is from the maternity dashboard, which we will go through shortly as well. So just you guys just remember that sometimes we pick these topics from maternity dashboard as well. We go in detail at that stage. So first of all, you need to then identify the problem, or in simple words, you need to choose the topic of your audit or the condition you want to audit, just like as we have taken the shoulder dystocia, particularly for this presentation today. Then the second step is then you define the gold standard criteria. So if you want to compare the your management of shoulder dystocia in your unit, who are you going to compare with? Obviously, you need to have some standard to compare. And that standard will come from your NICE or RCG guidelines, because there's a guideline which clearly tell us, do this, do this. The next step and the third step is data collection. The data collection is all that information which you will collect from the patient notes. And to do that, you will actually develop audit tool or audit proforma. So, and I'm sure you've done the line somewhere, audit proforma, how that looks like. So audit proforma basically is, all those questions which you're going to audit. And then in front of that, there will be some boxes to say yes, no, yes, no. So for every patient, you will just tick those information. And at the end, you will overall see what is going on. Data collection. And for data collection, under data collection heading, remember, you need to develop your audit tool or audit proforma. And data collection also will involve you to describe and define your methodology, whether you're going to do this audit or this study retrospectively or prospectively. Retrospectively means, the time has already gone. So we will say, right, okay, we're going to do this audit from July 2019 till December 2019. So that's retrospective. Or sometimes you do prospective studies as well, in which obviously we will take from now onward the first 20 patients will be, will have shoulder dystocia, and we are going to actually collect data from those nodes. And then the next step is, when you have collected the data, obviously then you need to do the analysis of the data, and then, look into what and how, and, and then recommend the changes. If we are not, performing according to the national standards, then obviously you need to recommend the changes as well. So it's not only you who will be recommending the changes, they will be done by the team, and we will go through that as we go through the details. So there is no benefit of doing, there's no purpose of keep doing such a lengthy, exhaustive exercise if we are not actually going to implement those changes, right? So then we need to make sure we call all the people who are actually involved in the whole process of managing these patients when we have shoulder dystocia. They all are given that message, and these findings of the audit, what happened, and also the reasons why we were failing not to meet, and also the suggestions how we can improve it. And then all of them will together make a plan as well, then how we actually going to now make these changes. Do we need extra resources to do that, more staff, more time, more money? But how are we going to do that? And then you need to define the time as well. It's not something just leave it. No. So we've done the order. Yes, we're going to implement these changes, and then we have not given their responsibility to any named person, and we haven't defined the time as well. So these type of things then kind of never happen. So that's very important as well. And finally, your 6th point method is, obviously, if you have done that all hectic exercise, you apply your, use resources, apply those changes, then it doesn't make sense if you don't actually measure and re-audit after 1 year to say, after doing that all exercise, what change has been and what improvement have happened into that particular clinical practice. So in our particular case, we're going to take shoulder dystocia case. So then again, that's the same thing we have just gone, like how you identify the problem or choose the topic of your audit. So one is from maternity dashboard. So maternity dashboard means if our service shows that we are actually performing significantly and consistently below the national targets. In particular clinical practice, like our cesarean section rate is actually always, most of the time, more than 25% or 23%. Then that will be something as well for us to actually do the audit to find out why we are failing to achieve that target. We also then can use this to measure the improvement after the implementation of new guideline. I've just said, like, when some new guideline comes in place, then after some time, you have to measure that as well as all the staff actually following that now. Review after severe, significant, or repeated risk incidents are near me. So sometimes they might be just very, severe incidents has happened, and we have picked it up from our risk management or incidents reporting. And then from where we thought, well, this has happened. Either it has been so, bad, we need to run an audit. So, for example, just an example, as one of the recalls where there has been a stroke or injury, yeah. In that one, we said ideally, the wrong instrument is being picked up from the trolley and being used, right? Although there has been a guard system in place that the ST2 also should know what instrument needs to be done. The scrub nurse should know what instrument needs to be used, and it's a scrub nurse who will pass that instrument to the surgeons. The surgeons are not supposed to pick up the instruments direct from the trolley. So what went wrong? Why that happened? So when we try to find out, say for example, the ST2 actually just picked up that trocar from the trolley itself, right? So why the nurse didn't pick up? So and then we find after the discussion with the nurses and the scrub nurse that most of the time surgeons just pick up, doctor. Right, okay, well, why that is happening, it shouldn't be happening, and see, then we ended up on this significant incidents. So then we will do the audit on that as well. Then that can be a reason to do an audit as well. Then audit on seeing how that actually the relationship between the scrub nurse and the surgeons, basically that pathway, how is that working? The instrument, are they sticking to that one? Or that's, yes, there's unit practice. It has become the practice in that unit that the surgeons are they are all becoming a bit casual in their behaviors. So the surgeons are saying the instrument, and sometimes they just are picking up the instrument straight away from the scrub nurse trolley, and the nurses are not telling them off either. Yeah, so it can be sometimes as simple as. So sometimes, yes, these type of significant incidences can also make us to run audit. And sometimes patient complaints. So say, for example, we start getting repeated complaints that the patients have to actually wait that long. The patients are saying we have to wait for like an hour or 2 hours for our time of appointment to be seen. So there was a delay in being seen. So there have been few complaints coming through. Then we need to do an audit as well to review basically our pathway to see why we are failing actually, why our waiting time is so much. Do we have enough staff then dedicated, appointed for those particular clinics, or what's going on? Yeah. So then we need to find out and apply the changes. And sometimes there can be unsatisfactory, needs to improve rating from CQC. CQC is clinical quality control. That's another, this is a national body who basically, they come like every year, they will come and they will basically inspect different aspects of our surveys. So from staffing point of view, clinical, so they are like external body. And then they will give their report to say this unit is performing satisfactory, this unit is performing good. So they are comparing with the national standards and stuff as well. That's quite a vast, assessment they do. So if they have sent as well, like in this particular aspect, this service is unsatisfactory, or the needs to improve, then how we actually then going to in detail find out why we have failed in this particular manner. Again, you run the clinical audit to understand where things are going wrong and what we need to do. So yeah, so these are the sources, a few sources from where actually you pick up. Sometimes national targets we are not meeting, and they're nice guidelines that we set like for. So we're going to take example of shoulder dystocia here. So when we do any audit and data collection, so that was like, okay, identified, and then we have, you identified your topic, then you have decided which guideline you're going to use. Then next one comes your data collection. How are we going to do the data collection? Now, there are a few legal points regarding data collection. It must be anonymous, so no details should be actually included in your report or made on those performers at all. So no patient name, no date of birth, and no unit number, right? You will have a separate sheet in your record somewhere, because we say you need to have patient information to start with to pull the notes, yeah? But that will not be the part of the report later on at all. Then you need to, as I said earlier on as well, you need to define your methodology, whether you're going to do it retrospectively or prospectively. So you can either then you need to define your sample size. So when you do the sample size can again be chosen by two different ways. You can either define the duration of the study for sample size. So just like you can say our audit is going to run from July 2019 to December 2019. Then it's fine. How many cases we're going to take all of them. They can be 40, they can be 60, they can be 100. Or you can define the number of nodes. So you can simply say, I'm going to, I'm going to include or do the data collection for 50 patients managed for shoulder dystocia retrospectively. So you can define the date like from 31st of December 2019 backwards. Then the first, the backward in a chronological order, you will just, your admin people will pull out 50 notes for you. So these three are must, yeah? So you must define your methodology, sample size, and then order tool. Order tool is you design your performer on which you're going to record all that information. Okay, so what are we saying there? All that performer and how that is should like. So this is usually how this look like. Obviously, on the top, there are a few more, although anonymous, but there are a few more information as well. The patient, obviously, in our obstetric, all these women are, our patients are going to be females, all of them, but there will be like gender, age, and these type of bit of information on the top of this performer as well. But this one will be more clinical and relevant. So say we're going to actually audit these 5 main elements of that management of shoulder dystocia, right? So this is your performer will look like. So you will say, okay, macrobit maneuver was performed first, pediatrician was present at birth. Yeah, if you remember now your guideline, it says pediatrician should be present in 100% cases. Yeah, and when you're saying these scenarios for your practice, you also say the baby doctors will be there and the baby will be examined. So that's what it is. Yeah, the baby was examined for injury of neonatal by neonatal clinicians like. So the injury means clavicle or any, brachial nerve or anything like that. Or disease. So, but that done or not, has that been documented? Documentation is also important. So documentation should be accurate and comprehensive. So maybe in that unit, it's a routine. Yes, the pediatrician always come and attend as well, and the babies are examined, but actually they didn't document in the notes. Yeah. So pediatrician comes and says the baby's fine, baby's crying, everything's okay, give baby back to mom and goes away. And when you're writing the notes, or even the pediatrician, because baby's fine, they haven't done anything, they don't put anything into the notes. Or you don't mention there either, the pediatrician attended, baby's examined, no concerns, no injuries identified. So if you haven't documented that, even though they attended, it has not happened, right? That's where documentation is very important as well. And then was the risk incidence reporting done for this particular scenario or not? Because if we don't do the risk incidence, how are we going to actually then look backward to do the analysis to say, was there anything different we could have done? Yeah. So, yeah, so let's talk about, obviously when you do the audit, there usually is all main important points of that guideline management. So it won't be only these 5 questions you will be doing. They can be usually up to 15 to 20 questions. All the important points of the management basically will be there. So this performer, you will complete that for each patient. Say your sample size is 50 cases. Yeah, you will be doing this for 50, all 50. Once you have collected all that information, then obviously the data needs to be analyzed. Now, analysis of data, there can be different ways to do that. At trainee level, usually SD5 and those levels, the people, those trainees, because it's a part of training, you should be able to analyze your data yourself. But later on, what happens, because the clinical work and other things are so busy, in every trust and then under the trust, in every service, so gynae and obstetric, they will have some clinical audit team for them, working for them. There can be maybe 2-3 people. They're working. You can actually then send all your data which you have collected, all those performers to that team, And they will actually do these results and these analysis for you. They can just, do these figures on these for you and help you to make some easy presentations as well. So you have got this. So you have seen, say, for example, in our these 5 parameters, we saw the national standard is the guideline. So go back to the green top guideline and read the guideline. There you will say, now there will be number even given as well to say the, should be done, pediatrician should be present in 100% of births, which shows that the social baby must be examined documentation. Yeah. So that's the national standard. Now in how many notes, in how many of our notes actually we did find that we were doing, yeah. So, when we were taking yes and no, yeah, that's what is going to give our results then. So say we found after that all that for our first, so our first standard of the audit, although they say this particular maneuver should be done for 100% patient, we actually were doing that 90% of patients. I mean, we were doing these things, but maybe the midwives or whoever managed their shoulder dystocia, they didn't actually try out all these maneuvers in the order as they are described in the guideline. So we found 90% cases were doing it as a first maneuver. Pediatrician were present only 98% of cases. And the baby was examined in 90% of cases. So this doesn't mean the baby was not examined. Maybe the baby was examined, but it's not documented there. Documentation comprehensive. And when we say documentation comprehensive, means it has just been given all the important components of the information written over there, like the call for help was given, these people attended, this performed, baby was delivered within these many minutes, a baby delivered with this EPCAR, all these things, the pediatrician was present and all that stuff. So all information included in that documentation. And that was just a general story, yes, the patient has a shoulder dystocia, baby was delivered nicely within 2 minutes. And was seen by the baby doctors or by the pediatrician. Yeah, this can be the information as well. And the reason why we need these detailed information for 2 reasons again. Then why documentation is important. Number one, if the things go wrong, then this is the documentation only. We will review and then get the information what went wrong and why it did go wrong, and what we need to improve. And the second, if this patient is going to sue us in the court, it's only our documentation which is going to then help us to justify that we did all according to the national standards that it is recommended. And still this happened because it's unavoidable. But if I have done everything 100% the way the guidelines say, but I haven't documented those things, then it has not happened. Then I have no ground to stand on. Okay, so I will be in trouble. That's why documentation is important. And then risk incidence reporting was done in 76% of the cases, right? So what happens is then, do you say the outcome as well? So obviously we didn't meet any of these criteria. Yeah. So what do we need to do then? Right. So there comes then the recommendations. Okay. So again, our standards list will stay same here. What was our outcome? We said not met when we compared on the back. Yeah. When we compared here, we know we didn't meet it. So that will come here as well. Findings. The person who is doing this or all the audit, when I'm doing an in particular patient, when I said the pediatrician is not present, I have ticked no on my initial performer. Then I will also try to find out why, basically what happened, what particular. I would like to maybe talk to those particular clinicians and try to get information why particularly what happened, right? Why the pediatrician was not there. So these are that a little bit of inquiry and findings, what basically happened, right? So say, for example, these are just, self-created. It's not some real audit. It's just like I have just made just for you guys to help understand. So for macrobit maneuver was not performed first always, we found the reason that most of the time this happened in the first 3 months when the rotation takes place for the trainees, right? So the new trainees come in, they are still, having their induction and all that, and there was not enough time for them to go through the guideline maybe. So that's why they actually were not sticking 100% according to that. So that was the reason we found. So what we should do then? Induction program, we should need to then, you can suggest by saying we need to actually include the management of shoulder dystocia into the induction program of the new trainees. Induction program is when the new doctors join somewhere or the rotation of these trainees happen when they come to the department. the first 1 week they are given induction program. Induction program means then they are given like important on these important conditions management, brief summary of the guidelines, how we do them, different presenters come and have them, and all other processes of the unit as well. So they become familiarized with the system, familiarized with the treatment and important things. That is called induction program. Okay, so we want that to incorporate into induction program. So who should do that? Because if we just simply leave it, who is going to take responsibility? We all got busy clinics and everything. Nobody will basically take it ahead, but you need to then nominate a person as well, not you necessarily. This will happen in that meeting. Okay, after discussion, then somebody will take the responsibility, right? So say I said Dr. Labor Ward, any XYZ doctor, right? And by when? So you give like maybe 2 months or 3 months time, should say, by this, they need to, this particular person need to actually complete this. Pediatrician was not present, not met. Why? And we found that actually, when we talk to the pediatricians, when we look back into the notes, we have noted that call was sent to pediatrician to attend, but they didn't come. So then we went and talked to the pediatric staff to see, whoever the lead is, to find out, like, we have been calling and the pediatrician doesn't come, what happens? And then we came to know that they actually are quite short of staff. Say, for example, 2 of them are off sick and, somebody has retired and they're not been able to recruit a new consultant or whatever, blah, 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 right? They were short of staff. Okay, so what we can do about this? The plan of the recommendation was that we need to meet pediatric team to find out the solutions then, what we can't do, because this can't be compromised. These babies needs to be seen by pediatrician immediately. Then we said, okay, who is actually going to then make sure that this meeting happens and some plan comes out? Dr. XYZ from Obs and Gynae consultant, and then some Dr. ABC consultant from pediatrics. Yeah, so these 2 consultants were then given, they will set up a couple of meetings, both of them sit together, and then they will see, okay, how are we going to address this? And they also need to complete that exercise by December 2019. Regarding documentation, we said it was not comprehensive. We didn't meet the standard. Then we tried to find out the why that didn't happen. And we found because there is no standard format of the documentation. There is no standard performer. Actually, the college has given a standard performer documentation for shoulder dystocia, basically, which includes all those information, you just need to fill in. So we found because everybody, and we all are different, even we can be very good clinically, but some of us may not be very good in documentation. They just briefly write down 3-4 lines and that's enough. But if there is a one standard performer, which says the pediatrician attended, baby seen, they all are there and you have to say yes, no, then even if that person will go through that as well, yeah? So there will be a standard way. So then we said, okay, so what is the recommendation? Print, there is RCG performer actually given one standard national performer that can be used. And they can be printed and put into a folder on the labor ward. So the doctor or whoever is going to write the notes after who have conducted the delivery, when they sit to write on those notes, they can just pull out one of those performer from that file, attach into the patient notes and just complete it. It's more quick for the doctor as well, also then to just complete, and nothing will be missed. All right, so let's give this duty to, say, one of our receptionists or other admin clerk to say, you need to, we will tell her this is the link, you can get this and print them, and also then keep checking on regular basis as well that there are enough performers in that file all the time, they don't run out. And let's give her time as well by 2019, December 2019, you complete that. Incidence reporting, we were lacking behind as well. And why that has happened, from that so the people who, doctor or midwife who conducted that delivery, when the person who was conducting that order went to them to ask who he identified that these particular people hasn't actually reported the incidents, then we came to know that the person said, oh, I didn't know actually I need to do it. I don't know how to do this. Yeah, as your trainings, there's a part of the training. You get a scenario in the exam as well. This is your training, and you are supposed to actually teach him or her how to complete the incidence form. Yeah, so that's very important. So then we said, okay, what can be recommendation? Teaching sessions and risk management and the importance of the risk reporting. And then somebody needs to given that duty as well. Say one of our ST5, ST6 trainees given that responsibility. Then you incorporate these teaching sessions into routine educational program of the unit. and that person is also given the time till December 2019 to come us to tell us basically, put this on this teaching in on these dates, so that can take place. Right, so this is like the clinical standard outcome. So this one is recommendations and implementation. So, and why we give this much of time? What are we going to do? Because if we just say this is going to be happen, we need to define a time, Although when this meeting happens, we do call the whole. So once you have done this much of data analysis and you have done this homework, then you call an audit meeting. And the audit meeting is, you do call, so there will be a whole unit basically. We do have one audit, a clinical governance meeting that is called every month. In that session, so there's a 4-hour session, and in that session no elective work is being done, only the emergency work is done. So the maximum staff actually can go and attend that clinical governance meeting, in which maybe there are some orders being presented, some incidents will be discussed or whatever. So the maximum learning can happen. So there will be pediatrician will be invited to this meeting as well. Almost all the midwives will be there as well, other than few on the labor ward who are dealing with the emergency for that day. So they all will be there. Our discussion will take place. So you have done up to here mostly, and you have given some suggested recommendations, but these suggested recommendations will be agreed after the discussion with all the consultants there, all the other teams there. And then who is going to do that? This will take place over there as well. And you will add up by saying this person will do this. And then what happens? So we gave the time up to December 2019. So say there was 2 months from, so we were presenting this audit in October 2019. So we gave a couple of months to these people to do that. And then from December 2019, when these changes are, we're going to send another circular to all the department and stakeholders like midwives and everybody who can be involved in shoulder dystocia management, to say that these are the the arrangements now, and if you have any problems you need to talk or raise these concerns, but you need to make sure now in 100% cases the pediatrician is present, documentation is done according to using that RCG performa and all that stuff. Okay, so you have applied that, so we will say this will come in effect, this will be implemented from 1st of January 2020. And then what we need to do, so then after one, that's the 6th step, and the most important step is completing the loop, this is also called, and re-audit after 1 year. Yeah, to see now then, after all these findings which we found, we recommended, we suggested, know what has happened, has now the staff started applying all those, right? And then we'll do another re-audit. And then the same exercise will happen. You will collect the data, you will see what is happening, then you will put the results. But only different thing now you need to do is, here what we did was we compared our results with the national standard. In re-audit, we need to compare our results with national standard. They need to be there anyway, because that's the tool we are assessing our performance against. But then we need to put these results as well to see how much we have improved from this. Okay, so your re-audit will be then presented something like that. Okay, so again, the same. Now, what is important for re-audit? There are a few things which must remain same in re-audit. You're going to do the same standards again. You're going to measure that. Okay, that's the only way you can compare it with your previous audit. Yeah, and the same national standards you need to use as well. So then you say, okay, so all these, for these standards, according to national standards, should be applied in 100% of our patients. In initial standard, we were doing McRobert was applied for 90%, pediatrician was present 98%, blah, blah, this one. And then we did all that exercise, this one, in which we suggested and applied the, so we should see some difference now, yeah? So although we still haven't met the national standard, if you say, yeah, it's still 97%. We haven't been able to do 100, but what is reassuring? We have improved from this one. So from 90, we have come to 97%. And our pediatricians are present in 100% cases. So we improved from 98 and we are meeting the national target as well. So you will be, the outcome will be now described like this: improved, yeah. And if it's target met the national standard, you say target met. No, this one is improved as well, because we still hasn't met 100% standard, but we have improved from 90 to 97. Improved, target met, right? So this is how you will then present your re-audit. So this is the typical part, the audit itself. Now, what is the pathway to do the audit? So in every hospital, there is one overall trust audit department, and then every specialty do have their own audit team as well. And then each audit team, you do have your own clinical audit lead as well, named person basically, who will be keeping an eye on these and making sure that these audits are taking place, which, you know, on the topics we need to take. So to start with, then you have one audit, this is called like proposal performer, like whoever is want to do is a consultant at the training. So these are standard. Again, every trust have their own. So you will then write on your name here, which department are you from, your title, your contact details, order title. So this one is actually to inform, you will send this to the trust audit department to say that in gynae, ops in gynae, we're actually going to run this audit. And then you will send this to your own ops and gynae audit team as well to say, I want to do this audit. Is this a reorder? If it's the first time, you will say no. If it's a reorder, you will say yes. Why are you proposing to conduct this audit, right? Why was this topic chosen? So then you will tell the reason, you know, and on our maternity dashboard is picked up from maternity dashboard that we are actually, you know, not meeting the national standard in the management of shoulder dystocia. This is what you can put here. What standards you will be auditing against? So this was our gold standards, you know, we will say RCG guideline or green top guideline, and describe the audit tool you intend to use. So audit tool will be that pro forma, which you have structured to collect your data. Okay, so you will apply that one as well for the audit department to see what you're using. This is the other side of this audit form. And then there are a few things here. They can be different for different trusts, but mostly like that. So please take the additional reasons for carrying out this audit, what this actually audit is going to help to improve the clinical point of view, because it's not somebody just want to see what is going on. It needs to be cost effective as well, because somebody is going to run this audit, so that person's time, some resources will be put on this as well. So you need to tell her, how is that going to help? Okay, so it's a patient centeredness, because we want to improve the patient care, this patients, you know, and it's a policy and guideline recommendation as well. You will take that as well. Service improvement, because it's going to improve your risk management. Okay. Any other reason, if you think other than that, then you can write down there. Each audit should satisfy all of the following. It should aim to improve the patient care. Yeah, that's why we are wanting to see whether we're doing. It should be multidisciplinary where possible. So it is multidisciplinary. We're going to involve our midwives, pediatrician, and everybody into final plan and everything. It should have support within your department, including a willingness to implement the changes. So it should be something which is really genuine and needs to be done. Because if you do some exercise, other people don't actually agree this was need, or there is any need to make this change, they're not going to implement that change. Which usually doesn't happen. Obviously, when you choose the topic, you have a discussion with your consultant and lead consultant, clinical lead as well. So usually do this. And then data protection legislation. This is very important. The data protection legislation means how you're going to actually access those patient notes. So it's not like you will yourself go and just pick up the notes. No, you will send this copy to your audit team of your trust, and also to the gynae ops audit team as well. And then there is a named person over there who actually will then look into this audit. And then, you know, you have given your methodology. We said at some stage you will give your methodology as well as retrospective of this, and these number of notes I need. According to that, that particular person will give you the list of patients who are managing that time. Right. So no, these days, because everything is, we have our online record system. So she will send you the identification of those patient lists so that you can actually access their notes online and get the information for your performer. A few years ago, when obviously it was a paper copy, then they will actually pull out all those notes for you and just leave with you in your office, wherever your office is, for you to complete. But they will bring those notes for you. That is one thing. Second legal responsibility is that data must remain anonymous. So you shouldn't actually know where those patients should be identified, even in the meeting discussion, but you shouldn't be talking about the name or anything like that. Third thing, you should access only that information which is important. So you will go directly, the initial list which will be given to you by the data person, will tell you actually the date of admission of that person for that particular treatment for shoulder dystocia. You should access only that part of the notes. It's not just, by the way, let's say, what happened before and what happened afterwards. No, you're not supposed to go to the information other than that, even within gynae ops notes. Okay, and because here now, even in the main notes are now as well, the patient's all other record is there as well, like medicine, surgery, and all. So you're not going to, look at the address, by the way, where is this patient from? And then you find out she's actually your neighbor. And then you just go through the rest of the notes as well to see what else is going on in her life. This is serious legal breach. Okay. And for these all different type of reasons, you're not supposed to basically access the information other than which is necessarily required. All right. So that's why data protection legislation is important you to be aware of. Have all the potential stakeholders been identified? Yes. So who are the potential stakeholders for shoulder dystocia management? It's your trainees, your consultants, midwives, midwife trainees if there are, and then your pediatric team, then your audit team itself, because they are the people who sometimes need to provide you all the resources. They have to pull the notes and everything. So there needs to be, and that's why you're sending this pro forma to them. Okay. And then GPs, because when these patients are discharged in the community, in case if there was any injury to the baby, or even if not, when you send the discharge letter, you will write down shoulder dystocia and stuff. So if there is any problem in the future, then we know, right? So GP is a stakeholder as well. So these are the stakeholder people who are involved or will be involved in future in this management. And you need to identify, because you need to invite them all and send these research information recommendation to those people if they haven't come into the meeting. They will attend the meeting, this will be given to them. You will email that, net recommendations to all of them, and you will also send them postal to make sure this then information reach to all those people. Otherwise, there is no benefit and there's no purpose of doing that all lengthy exercise if you're not actually going to make sure it gets to the people who are supposed to implement these changes. All right. So that's when, and sometimes they ask you to write on the names as well of those teams. Has a literature search been undertaken? Yes, because you read your guidelines from where the sample size. So here you will write on, either you will say retrospective, as many notes within this much duration, September to November or whatever, or maybe 50 cases retrospectively from this date. Length of the time to audit and target completion date. So you need to give some idea as well. It's not like you made that commitment because your consultant has identified from maternity dashboard, and the consultant asked you to do this audit, and you say, okay, I will do that. And then after 1 year, your rotation is complete, you are going to move to the other hospital and you haven't done the audit. You see what I mean? Yeah. So you need to give actually the date as well. In this time, I'm going to complete it. And then this is kind of your declaration. I confirm that all data collection storage will comply with, whatever the name of the trust is, ICT policies. Again, this is actually more just legislation, data protection. And then you will sign here because you're going to desk audit sponsor. Audit lead will be, there will be audit lead, the consultant who is the audit lead for that department. And then audit sponsor, basically this, audit team, the person who will actually review this pro forma and who's going to make note there and send you go ahead. Yes, fine. Yes, you can carry out this audit and we will provide the support you need from us. Date received, they will write on which date they received, and date discussed, like when they have discussed within their team to make sure, yes, this audit should be done. It can go ahead. Right. I hope it's clear now. Yes?
Dr. Safia, can you repeat this, the literature search being done in the
So the search being done means, from where you have identified your gold standards. Yeah. So have there been any other research you need to do? So our guidelines, they already include the search and studies. Yeah. So you can just say yes from your guidelines. Yeah. You have done that search.
So it's from the guideline.
Yeah, and sometimes you might read yourself as well. If something is not very clear in the guidelines, just, all these papers which are published to see what actually is, how it should be done.
Okay, thank you.
Dr. Safia, what about that stakeholders? You said the performer will be sent to these stakeholders as well? Or just
No,
the
not the
information will
performer.
be shared, the result will be shared?
No, not the performer. Our results and suggestions of what we are going to change and implement. Okay, and
Okay.
the
Victoria,
results.
please define the stakeholders, because there was in that structured discussion, who are the stakeholders?
Who are the stakeholders? So
Yes.
in this particular case, as I said, like you need to imagine right from the beginning of the patient till end, who are the people who actually are involved in looking after these women and their babies. So it's yourselves, so obstetricians, trainee obstetricians, midwives, trainee midwives, then your GPs, yeah, and then your pediatric team. All right. So these
So
will be
it's
all
not
the
nobody from the finance or the donation organization or these things.
okay.
I thought
So
they are the
if
funding organization.
okay, so if there is something which will require money and you will need to have the allocation of funding, we actually will be talking on that in our development of the pathway for early enhanced recovery program. So if you need funding, you know, you're doing something for which actually maybe, for example, you need to have some major new equipment. As a result of audit, you think you're doing some audit on the ultrasound findings, there may be something like that, you know, waiting time of the ultrasound in early pregnancy assessment unit. Yeah, so maybe your audit is this, and in that one there is a possibility that the waiting time is quite long. So we see EPAU, we see the women, we should ideally be able to, you know, do their scan straight away or next morning, but because we got only one machine maybe, or one operator, or two machines and only one operator, and because of that there is a waiting time, and although they needs to be done immediately, but we actually are giving them time in 3 days time, just simply because it can't be done. In that one, now we understand either we will end up buying a new machine, or maybe to recruit a new another sonographer. So then we see you need money for that as well. Okay. In that one, yes, you need to then involve the managers and the stakeholders. They will become a stakeholder as well. But that is slightly different process then, funding in that one. Then we will need to basically send them a plan that is called project plan. Then we will need to justify them, make a small case basically to tell them that this is happening in our here. And you know, we have done this audit, or we're going to do this audit, and then, you know, as a result we may need to start with, you say we may need to do that. So you just make them kind of heads up that, you know, we may need to actually apply for some money. And once you have done the audit, and now you have certainly found that it is very important, it is must that we get a new machine and a new operator as well, then obviously that involves money and everything in recruitment process. Then you will make, that is called a business case plan. And then you will write on and give, you know, your audit findings as well to back up your business plans, to say because of this reason these are the findings and these are the complications happening then, and these are the consequences of having these, delaying these you know, the scans. So that's why, you know, it's important that we, you know, we need a scan machine and a recruit another operator as well. Then you will send it to them, then they will become a stakeholder as well in this particular one. Because there's nothing we need from funding point of view. We don't need any extra money here. All we need is, we obviously need to, whoever is going to do this audit, that person will need some time to sit down and do, in addition to her clinical. It's not like that person is doing clinical duties as well, and then we're wanting them to sit extra time in the evening to complete this audit. So in this country, all the trainees, consultants, everybody do have, they are called continuous professional development session. So say we all get at least minimum 4 hours session every week. And then we have administration, admin session as well, at least 1 each in trainees level. In that, they can either do their audit in their continuous professional development time, 4 hours, their dedicated time, or into their admin time, in which they can do this, and they do like review their results, which can wait and has been just waiting there, and all that stuff. These are being done. So we don't need extra resources here. So we don't need to involve the finance team. So finance team is not our stakeholder. Stakeholder means the people involved taking care of their particular patient or their process, and then possible those people as well who we may need to implement the changes, right? simple for you to understand for different scenarios who needs to be stakeholders. It will be more clear, this concept, when we will do enhanced recovery, because that one is development of pathways. So that will reflect, explain you very nicely.
Sorry, Dr. Sophia, and your slide number 4, where it was recommendation and implementation. In this slide, where you assign people to do the follow-up or the causes, I got confused here. This recommendation, you are, as an auditor, you will recommend it and you present it in the meeting, or in the meeting itself, you will assign the people to find the problem.
Okay, so up to this, up to the recommendation things, these will be done by the time we are presenting this, right? So you will come up with some suggested recommendations as well, because once you have done these, the results, and you try to find out the reasons as well, then obviously you're going to discuss with your clinical lead, your supervisor consultant, and also the audit lead consultant as well. And then you will have some of these recommendations here. These recommendations will be then from here onward, this will be discussed and finalized in that meeting. So then this will be, you will open up by saying, this is the recommendation, right? And then there will be discussion. And if all the people, the stakeholders, so-called, if they are there and they feel, yeah, that sounds sensible and that sounds reasonable to do that, and it's achievable, then it's fine, it stays a recommendation. And then you say, okay, so let's identify the person who will do. So most of the time people do volunteer themselves by saying, okay, I will, look after this and make sure I can do this. So otherwise, within the team, then you will decide who is going to do that and by when. So these two particularly will be done during the meeting, and this will be agreed in the meeting as well. And sometimes you go with your recommendations, but there may be the people from the meeting who can give some additional recommendations as well by saying, I feel if you do that, that can also improve this. So that can be added into recommendations as well. So from here, recommendation, who will, try to complete it and what time, this will be discussed and decided and finalized in your audit meeting. Is that clear?
Dr. Sophia.
Yeah.
So the stakeholders, it will be not all the staff, 1 or 2 person from the physician, 1 or 2 person from the midwives.
No. All the staff. Yeah.
And they are the one who are collecting the data and filling the performa, all the staff also?
No. So the data and this one is the person who will be assigned that audit, right? So say, for example, I'm the clinical lead of my service, right? Yes. And then on the maternity dashboard or whatever, I found actually we are having too many cases of shoulder dystocia, whatever. I identified that this should be done. This audit needs to take place. Then I will allocate this audit to 1 or 2 trainees, my trainees, right? So say I will say, okay, so Dr. Nabila and Dr. Samar is going to do that. So I will send you the email to say, and then obviously we will have a little meeting in which we will discuss our performance and these standards and these things, right? So those 2 people will be performing the audit. So then I will discuss with you all that initial steps, what recommendations and what standards which you can include or give you some help. The trainees usually know by themselves. So this guideline can be used, this can be done. This performa we will complete together to send to the audit team of the trust and also the audit team of the gynae unit. I will sign here. And this one will be for the audit department. They are sponsors, and then we will send it off. And then, once that is gone, then you will contact your audit team to send, and you will send your email as well to say them. In addition to this, in the email, you will say, we need these many notes for data analysis or something. And then she will send, or he will send those notes and all the communication to you. So you will complete all this audit. Then Dr. Nabila and Dr. Samar, for example, they will do all they will find out, they will do analysis themselves or with the help of the audit team. Then you will get this up to here, and then we will have a discussion again. So you will come to me again. We will say, okay, yes, that's fine. Yes, okay, so that happened. We have a little discussion. These recommendations we will put on in our point of view, this should be, and then we will take it to the meeting. No, so these are the people who are doing. The stakeholders are those people who we want to convey this message to make it a part of their practice. right? So it's going to be everybody, all the obstetricians, all the trainees, all the midwives, because any one of them can have a case of shoulder dystocia, right? So, and all the pediatricians as well. Who knows when we have that case, who is on duty? So the stakeholders are all of those people. Stakeholders means, word stakeholder itself means the people who basically have, who can be affected, who are going to be affected as a result of that change, or who needs to implement that change, who will take that role and that work. They are called stakeholders, right? So this will be all the doctors, this will be all the midwives, pediatrician team, and your GPs, because they are the people who will be involved and who actually needs to then implement these changes. Yeah, all these discussions which we have taken place. So they are the stakeholder. And the reason identified mean, because then we need to, it's important to identify here, because then we need to invite them all for that meeting. Then we also need to send, email the information or recommendations, the final guideline which we will develop again, to all of them through emails as well and through their post, to make sure that this information get to all of them so that they can then, you know, make it a part of their routine practice. Is it clear now?
Yes, thank you. And the audit team, it will be like HR department, like non-clinician.
No.
They are responsible for.
Okay, so the audit team is, as I said, like there is a lead clinician, we call it, and they're usually one of the consultants, but it can be one of the senior midwives as well. You know, the person, again, as I said, like that person will identify, say, for example, I'm the audit lead of my team, right? So then you usually have a consultant, you have one of the midwives as well, usually one of the senior midwives, and mostly it's a midwife coordinator, basically. So you will have these two people, and then you will have these people, the audit team, and they are more like a clerk type or managerial type of team. They're not clinical people necessarily. They don't have to be clinical people, okay? So they will be working for you, like to get the notes for you, do the analysis, statistics. At our level, like at consultant level, sometime maybe I want to do some national quick audit. I might quickly do the data collection and stuff, but I don't have enough time basically to make their presentation and all that stuff. So they will basically do this all stuff for me. So they will do the analysis, put the results together, and even put this, you know, this presentation together as well for me to say, and then I can overgo and tell them to add anything else, or to my secretary to add something else or whatever. You know, they will be kind of, they will provide you that support. Okay.
And this clerk people responsible, for all audits all over the hospital, not only the gynae.
So as I said, like there are these teams are at two levels. One is overall trust audit department, who will be overall look. So once we have prepared our report and we have presented in our, and we've done this, then that report will also go, it will stay in our gynae audit team as well, and then it will go to the main hospital department as well, so that the hospital overall can show in all the departments, to meet the good practice, they are doing audits and everything. Okay. So one is the trust overall, which will be looking after all the specialties, and then every specialty do have their own audit team as well. So your interaction will be mainly with your own unit audit team.
Okay.
Dr. Safia, do you need ethical approval for every audit?
Okay, so ethical approval will be required where there is any ethical issue. Yeah. So in this audit, mostly these clinical practice audits don't need any ethical approval. Ethical approval team is their separate team. So they are called, you know, the committee of ethics. So there are like, that's on the board, that's on the trust levels. There will be 5-6 members of that, which can be from different specialties. Ethical approval is applied when you think there can be some ethical issue over there. For example, now in this one, there is no problem. There's no reason, we are not identifying any patients' names there. We're not basically going directly and speak to the patients. There is no harm that we are going to particularly discriminate any race from the other or anything. There's no risk like that at all. So there is no ethical issue there. So we don't need to worry about. where we need the ethical. So say, for example, stem cell treatment. Okay, so we want to do an audit on that, or even we maybe not audit, we want to do a study on that to say, okay, so collecting the cord blood, you know, getting that for the stem cell use and stuff. That is, so that is ethical issue there, because you know, from the point we are taking the cord blood, which actually is the property of that newborn baby, but who are we taking the consent from? We are taking the consent from mother. Yeah, because that consent is taken beforehand when we say we will take, you know, the sum of the cord blood to preserve as a stem cell use later on. But that actually, as soon as the baby was born, that cord blood was actually baby's property, right? So, but the baby is not in a state of giving the consent. So that's the ethical issue now here. Is it right? You know, that we are saying the mom has given the consent, she's fine, but actually that is baby's property. And what, you know, in future, maybe this particular person, when he will become an individual, may not like that his genetic information, blood or whatever was actually used to do some scientific study or even to help somebody else's life. So these are ethical, these are type of ethical issues. Or say, for example, you are going to do some, where you're actually going to survey, and the survey involves some sensitive type of questions maybe. Say we did establish one local surveys a few years back for sexual health needs of the Muslim women. So no, because we are targeting particular group, so it can be sensitive then how that particular group actually take the sexual health. Is it quite sensitive matter for them? Is it okay actually to go and talk to them and ask them direct questions about that? Do they like actually? Is it acceptable in that particular group to talk about sex? Yeah, so that is then something where then I have to basically write on my idea, the need for it, why it needs to be done, because this particular group basically then find it difficult basically to come down and talk about their issues. And for that reason, most of these women basically do have undiagnosed STIs, which can lead to chronic pelvic pain and which can lead to additions and which can lead to infertility, you know, and these type of things. So for this one, then yes, I will apply to, I will send my recommendation and plan to ethical committee as well for the approval with my performer as well, that these are the questions. Then my performer will go to them as well, that these are the questions we're going to ask. And in that ethical committee, then they will have, and then we'll invite all the trusts do have, you know, faith-based nominators as well. So they will call that particular person as well, whoever is actually for their trust, to check with them, you know, some maybe to check is, will that be all right for this study to go ahead. Sometimes they recommend, they do some recommendation by saying, can you change your wording slightly from this way to this way, because we feel this is quite sensitive and it might, you know, not be acceptable for your cohort of people you want to approach and these type of things. So if there is, you think there is some conflict thing, then yes, ethical, that is recommended. But for the routine audits, no. Ethical committee is different. They're separate, and you need to sometimes, yes, for audits you need them. Sometimes for even for search studies, research projects, then you need to get them if you think there can be some ethical conflict. But not this routine kind of thing now. Not for this particular couple of examples we have. Okay. Right. Then OSATs. So I have put the example of LSCS, but I will try to use the examples you guys actually have got in the exam. Well, let me just briefly go through those sets first, what those sets are. And a couple of points maybe for your own notes. It will be a good idea to write on a couple of points for your memory later on to reflect on, well, to consider basically. Okay. So OSATs basically, I hope all of you at this stage know OSATs is a standard process of assessment, training assessment of our trainings. And this assessment can be practical skills. They can be like even history taking, difficult communication, breaking bad news. So it can be related to communication. It may be practical skills. simply not tying episiotomy, LSS, hysterectomy. So for every skill, there is a process the trainees need to go through to then provide the evidence that they are actually now fully trained to perform that particular skill independently and safely, right? So the word safely is very important. So that needs to stay in your minds, okay? So, and then how are we going to do that? There needs to be a structured process for that one. Well, it can't be subjective. Like I might have, a couple of trainees, they are very favorite to me, and I like them, and I'm just going to sign them off easily by saying, oh yes, I know, I have seen you doing this all stuff, so I'm signing you off. And then I have a trainee who might have actually sometime not done the things the way I wanted to. I wanted to give her a couple of extra duties, and she refused by saying, oh no, my baby is not well, blah blah. And then I say, right, okay, well, yeah, okay, I'm going to sign your logbook, so I'm going to give you a tough time. So there could be a bias thing there. So to prevent all that type of thing, it's wide practice here that the assessments will be signed in an objective basis, so that no trainee is discriminated, or any trainee should not have any fear of getting discriminated either. That nobody should feel the pressure. No trainee or the consultant, even anybody, should actually feel the pressure, do something which they feel is not right, or raise their concerns, but they stop not raising, but thinking, oh, I don't want to actually make this particular consultant to become unhappy because he or she is my supervisor and she has to sign off me. So to eliminate all these type of worries of the trainees and to make it a fair and non-biased process, there is an objective forms. An objective means when there is a standard structure given by the college itself to say, you need to actually judge and examine and assess your trainees against this particular criteria. So that obviously needs to be, that will maintain the safety and quality as well. So it's not like just out of favoritism, you're going to sign somebody, but actually that person is not really that competent yet. And that could pose a risk to the patient's safety in coming days, okay? So to do that, we use these OSATs. The college uses this is form by the college. It's available on the college site. If you just put the OSATs assessment of performance for the trainees, you can actually get this form over there. So this form has two sides. So this is the first side of the form, and this is the second side of the form. So let's go first through the form, and then we'll go through the process. So this is how this form look like. So here will be the trainee's name, then trainer's name, the person who is doing that assessment, what procedure, what particular skill are we going to assess, for example, cesarean section or episiotomy suturing, clinical details and complexity. So it can be like, okay, so second stage cesarean section. So it's it's a moderate complexity. Because it's not simple straightforward, but we know it's a high risk cesarean in the second stage and need a bit more skill as well. So this is what you will describe here, yeah? Second stage food dilatation cesarean section. What is the degree of difficulty? This is intermediate, yeah? Basic is just some electrocesarean section or cesarean section, the first stage of labor, those ones. Intermediate, this one is intermediate. Second stage. Advanced is like say placenta previa and those type of surgeries, yeah? You will write on the date of the assessment. Encounter requires study in advance. Now this is very important from your exam scenarios point of view. And this one you will see only on the summative form. So this basically is summative assessment form. Okay, this will be used. I mean, they are similar forms, but the summative one will need to have this date as well. So the summative assessment needs to be booked by the trainee in advance. So the trainee will actually, if that's my trainee and want to do by myself, then he will actually need to send me an email or come and speak in person to say, I want this skill to be signed off as my formal assessment to take place. So I would like to book that. And I say, for example, whatever my CPD session is, we book a session for that. That must be booked in advance. It's not like he or she just happened to work with me and just said like, okay, so Dr. Jabin, I'm just doing with you today. So can I just do the cesarean section? And I said, yeah, that's fine, go ahead. And he or she does the cesarean section, and luckily it went very well. And then she come to me and say, oh, that gone perfect, you have seen it, I've done everything. Like, can you please no sign off my summative assessment? No, I'm not. because it has not been requested in advance. And the reason for that, why that is important, as I said, like it maybe it's just a one-off chance that this cesarean went right, but the person basically do not know in detail what complexity and what complications can be this particular type of surgery. So it's very important that that person go through the proper steps of the training to get the formal assessment done. All right, so that's why it needs to be. And before actually I will give this date, I will check few things on that training. I will check the formative assessment forms first. How many formative assessments she has done? Okay, and I'll explain in a minute what formative means, so that I know, yes, this patient actually, this particular trainee has actually successfully shown that he or she can do this particular procedure quite safe, and she has actually shown that repeatedly to different clinicians and under different stress or different circumstances. That means, yes, this person is actually now capable. It's not that this one-off just by chance happened to be nice and went perfect. Okay, so that's the reason. So keep in mind, you're not supposed to sign in exam scenarios. If the trainee is asking you to sign this summative assessment, very simple thing you need to first consider is, was this actually pre-booked? Did you actually requested this assessment in advance? If the trainee says no, then even he has done perfectly that one, and he has actually 8 formative assessments already signed to say this person is competent, you still are not going to sign off. You need to just tell this, that needs, this is a formal process of assessment, and there is a formal procedure for that, and that needs to be booked in advance. All right. Okay, so that's one thing. Then what happened? So this assessment is mandatory, and it's a summative tool as designed to. So it's a like kind of final competency sign off. So what you're going to do is it enables the judgment of surgical competency in this particular procedure. Yeah, that doesn't mean no, it's a second stage cesarean we have signed off. That doesn't mean no, this person has been signed off the competency for precedent of previous cesarean and for breech cesarean and blah blah. No, only this particular type of cesarean. To provide specific constructive feedback to the trainee about their performance, and we'll go that in a minute. And this one is just then the information about, you all can read this, why then, you know, what is this? There's nothing quite relevant. It's just basically why this is required, minimum of 3 procedures. Okay, we can go through that basically. So so this is a judgment to be made in this assessment relating to the overall performance observed, and these are the 3 components. You will be competent or working towards competency. So instead of saying pass or fail, or I'm going to sign you off, or saying I'm not signing you off, the terminology used is competent or working towards competence. So if that we are happy that person actually is able to perform the procedure independently now, then we will say this trainee perform this observed procedure competently, which in other words mean this person is competent. But if this person was not able to, actually we have found some, you know, the things which she needs to improve, then I will actually delete that. On paper, you will put a straight line on that to cross that, and you will just leave this one which says this trainee is working towards competence in this procedure, which means this trainee basically needs to work more on this particular skill and then come back again for the assessment. Okay, so instead of saying pass, fail, or successful or unsuccessful, or competent or incompetent, because they are quite harsh words, so instead of writing those and making the trainee to feel low, and you know, instead you just basically use these words. Okay, so this is very important as well. Okay, so but before you do this, just for this one information, just for the prerequisite theory. So trainees require a minimum of 3 procedures deemed competent per core procedure by more than one assessor, including a consultant or post CCT holder. This judgment is specific to this assessment only. So this form will be like for that particular skill, as we said, say second stage section. Now, what does this mean? 3. So that means when we say like there's a minimum of 3 procedures deemed competent, like this trainee has been able to basically get 3 formative assessments done already, where those were signed by 3 different clinicians, which should be the consultants or somebody who has completed the training of the consultant, but they still basically are not able to. They're registered as a consultant now. They have completed the training, but they still have not actually able to get the post of the consultant, and now they're still working in that particular unit as a senior trainee or whatever. Yeah, but they have completely. Post CCT means post training holder, like they have actually certificate of consultant training. So those people, right? So what basic? So in short words, basically, there needs to be, all of them needs to be consultants. Okay, in simple words, right? So now these three procedures, before he will come for the final procedure, it will be the same form though, right? But that will be called formative. Formative means that is to inform the trainee whether I'm able to do this or not. Am I ready to go for my, final assessment or not? But they need to have, even if they are perfect in one or two, they need to have at least minimum of those signed as competent, like this. This trainee performed the observed procedure competently. Is that clear now? So to make that one, then how are we going to say, whoever the person who is actually going to assess, how that person is going to decide whether this person is able to do this procedure competently or not? You need to complete this part of the form first. Okay, so this is very objective assessment here. So say we stick again to our topics, variance section, second stage, checking equipment and environment, right? So you all say WHO safety criteria and equipment and stuff means like, okay, was there anything different you need? You check with your scrub nurse, she knows the procedure and she has opened the right kit. Perioperative planning, for example, positioning, you need lithotomy position for this person, you need a left lateral tilt, you want this, or you want any pneumatic pressure stockings for this, or anything, any tilted different position or anything, what position patient will be, anything like that. Perioperative, this is one example about the positioning. It can be anything, this is actually perioperative is you check with your ST2, have you put the catheter in and have you done this procedure, unless you don't know, your trainee already have done this, so you know what to do from that. And yeah, so this is the instrument, you will be doing, this is how you will be doing. If that happened, you're supposed to do this. And if this person is at high risk of, say, BPH, then you're talking to your team by saying, okay, so she might go into that one. So is 40 units into trip ready as well? We will be starting that straight away and informing the anesthetist as well by talking, although this discussion has already taken place, but still just to make sure this is the risk, blah blah blah. So this is called perioperative planning. At the in the theater, before you start your procedure, just the final overall assessment of your situation and talking to your team as well, that everybody is aware what you're doing, everybody knows what we are doing, and how that is going to proceed. Technical ability. So technical ability is again like as this is second stage, full dilatation once the head is quite down. So technique is a difficult, so what was the technical ability of this particular training? How successfully this person was actually able to disengage the head from the deep in the pelvis, and how successfully this person was actually able to deliver the baby, either by, pulling up or pushing down, like that person was competent or comfortable enough actually, instead of trying to disengage the head down from down. What is, because some surgeons will, some consultant and some obstetrician will do, they will actually deliver that baby as a breech. So deliver the upper part first of the baby, the bottom legs, and then that will give more space to disengage the head, bring up. Some people find it is fine to disengage the head and use some assistant at the bottom end to help them to disengage the head. But you need to say how competent that person was actually to do that, and then also to prevent any complications. Selection of instruments and equipment, right? Do we understand here now that row card thing when that came in? Yeah. So this is also the part of your skill. You should be able to know exactly which instruments you need for this particular. Not only relying on your scrub nurse, assuming that she should know. Yes, she must know as well. That's part of her training as well. But you yourself must know which instrument. And sometimes you need to use some modified instruments. Sometimes you feel like, oh, I'm doing this by this clamp. Oh, no, this clamp. Can I just try this one then? Can I, according to the situation, if that is happening, are you aware that what can be the appropriate instrument? Sometimes you might need to even use slightly different one. Economy of the movements, like you're not either too slow to perform and take a lot of time, which obviously can result in long anesthesia and more tissue damage and more bleeding and all that stuff. Neither you should be so quick. Some of us feel, just the cesarean should be completed in 20 minutes. So they come out and very, in a private way. I finished within 15 to 20 minutes. No, we won't give you actually very good marks. I will be concerned for my trainee who complete the cesarean within 15 minutes or 20 minutes. Because it's fine, that was simple, straightforward, it went. But if you are in the tendency to do that, that means you're a person who can actually miss the bleeders, who can actually compromise. Your movement of the tissue was not very fine and gentle then, because rapidly you're trying to do, you are actually causing trauma to the tissue as well, right? So that's why economy of movement is important. Tissue handling is important. What was the tissue handling of that person? Completion of task as appropriate means the finally, like was he able to actually complete and deliver the baby, or he or she couldn't actually try to disengage the baby but couldn't, and then she needed to ask me to deliver the baby, or I felt it's a bit long now, I can't actually now have to say no, I would like to take over there and deliver this baby. All right, so that's not then completed, right? But because we had agreed about this assessment still needs to take place, right? So we need to write down this here. Communication with patients and the relatives. So that's after the surgery as well and before as well. Was there anything from consent point of view? You know, when you do the reconfirmation of your consent and all that stuff, was there anything you needed to talk to the relative or tell them? Most cesarean sections, the partner or some birth attendant is actually sitting, it's under in a spine, or patient is awake. Their birth partner is sitting next to them as well, talking to them. So are you actually reassuring? So we are struggling to deliver the baby for some other reason. Is somebody actually reassuring their partner as well to say, don't worry, you know, it can't happen in this particular type of thing. The baby is fine now, you know, because it can be quite scary experience for that person then. For the relative as well. So you need to make sure you're talking to the relatives as well. You know, just in angry and stressful circumstances, when I repeatedly tell you guys to say, don't ignore the relative needs as well. When they are stressed, you know, offer them a drink as well, offer them a sport and a counseling as well. So that's the part of the use of assistance. Again, use of assistance means you have one assistant assisting you as well, but then you can consider using a third person to disengage the head from the pelvis, from vagina. Yeah. So are you actually able to understand that you could do that? Or for some obese patients, sometimes we need to have more than one assistance, because we need one person actually to support the upper part of the abdomen to move the skin away for us to have the approach to the operating field. Communication with the staff. This comes, you know, when just a routine communication as well. Can I have this instrument? No, can I have this instrument? The nurses are doing, the midwives are doing the count, first count, when you are going to, you know, you have gonna suture your, and they do it. They will talk as well. The first count is complete. But what you aware, have you also checked basically before you start suturing the rectus sheath? Is the, you know, sister, is the second count complete as well? You know, so you need to make sure as well, it's equally your responsibility as well, or anything else. Some injury has happened. The communication, I will speak to my anesthetists, I will tell the team, I will tell the assistant, I will ask them to call this, I will call the blah, blah, blah. That all is communication with the staff. Forward planning, right? You know, when we say these complications can happen, your placenta previa, there can be difficulty, there can be atony of the uterus, this bleeding can happen, this bleeding can happen. Then we're going to give you syntocinon, then we're going to give the infusion, then we're going to do UAE, then we're going to do this RT ligation and blah, blah, blah. That is all forward planning. So if you are thinking this patient may bleed quite heavily, and then you may need your intervention radiologist to use uterine embolization. Although it is planned, it is not in the everywhere, but have you actually, before when you were starting your cesarean, did you actually give the intervention radiologist a ring to say, well, I'm about to do this surgery now, so I just want to make sure to check that you will be available if we needed you, right? So that person is aware as well, you know, that I may be called. So that's a kind of different forward planning. Or for placenta previa, you check to make sure is the blood available now? Is that in the fridge, on the labor ward, and blah, blah, blah. Yeah. Dealing with problems and our difficulties, so extension of the incision, hemorrhage, bleeding, then how confidently, how safely you actually dealt with that. It's not like you started panicking and as well at that stage, and you don't know what to do. Or start panicking, or you're taking too much long time, and you should have done cesarean hysterectomy earlier, but you was not aware of time and all that stuff, and you kept doing, you know, you're not able to, or you start panicking. I can't do it. Oh, this happened. I can't. What's happening? You know, I'm not able to do it. Documentation, as we talk, documentation is very important. It's a very important element in this country. So proper comprehensive documentation, and you see that in your exams as well. You know, all these GP discharge letter, correct, your junior has done this discharge letter, tell him how to do it. MDT refer, tell him how to do it. Operation notes. So documentation is just a lifeline, really. Safety considerations. So safety considerations again, all these stuff, you know, a lot of overlap anyway. Safety means you're aware with the nurse one. If it's you find some newness, you're not aware, you make sure that, you know, you check with the other nurse or the midwife to check, is that nurse, has she done this procedure before? Does she know what to do? And you check with your assistant as well. Has you done the procedure before? Have you done this? And not any other safety. During the procedure, you feel your assistant actually says, I'm feeling lightheaded. Immediately change your assistant. Make sure somebody is looking after this assistant now, you know. And then when we said something goes major wrong by your assistant, she may not be able to now focus and concentrate. Here comes that safety consideration when in our trocar injury scenario, we say, now, first, I will say to the trainee that this has happened in a calmer way. That's a safety consideration. When I said I will say in a calmer way so that she doesn't panic and move the instruments. Then the second safety consideration was I said, I will keep the trigger and direct my camera view all the time, right? That's a second safety consideration. Then I will check with my trainee. Is she okay actually to continue? But if she's feeling really nervous, then if it's not safe for her to continue, I will try to change my trainee at that stage, my assistant at that stage. Okay? So this type of planning is called safety consideration, and it may not be in every case, just simple safety things. So basically, before you will decide this, this final comment here, yeah, this trainee has performed competently or not. Before basically this one, you are going to complete this top bit here. Okay. So that obviously is going to inform you a lot as well, and your trainee as well, what the outcome is going to be, right? Now you need to give a bit more detailed feedback. Now, whenever you are supposed to give feedback or somebody is with you to do the reflection, always ask that person first. Instead of you starting, you didn't do this, did you do this? You could have done this. I think you did this very well. No, always ask that person to tell you first. And always start from the positive as well. So ask, what did go very well in this one? How you feel about this surgery? So what did go very well in this one? So that person will say, I did this, and I think I have done really, you know, I was quite confident. I, you know, apprehend that there can be difficulty in delivering this baby's head, and this blah, I did this, and to do this, I did this. So he or she will talk all positives here, and then you can build on that one and say, yes, I feel, I agree with you. Your time management was very nice. You know, you were quite focused. You're pre-planned. You know, you did this. Your communication and before planning was very good, and particularly I liked you said this to the, you know, blah blah. You have a plan B in place that if this doesn't work, this is next we're going to go to, you know, any of that type of things we should say that was really good. That comes like what could have been done better. So exactly this is so what you think could have gone better, or was there anything you could have done differently? Yeah. And that again, that person now will focus, and the trainees and all of us who we do that reflection and all that, we are open in that man. We all are trained basically to do our constructive negative analysis as well, to see what critical analysis, not negative, critical analysis, to see what actually needed to be improved. So then that person will then tell, okay, yes, I think I couldn't quite do this, or and even if we're going to sign off, you know, the person still there is always the place to improve, the space to improve. So the person will then tell, I think this one I could have done this way and this way, and then you build up as well that thing in your mind. Yes, I feel, you know, you could do this, and if you could have done this, could have been better. This can be done this way as well, but overall it was fine. You know, this can be done as well, unless you feel, no, there was something significantly wrong. And you just learning plan. So learning plan is then according that even if that person has nicely done it, you're going to sign it off this person. Still, on ongoing learning needs to be in place. So say, for example, I'm happy basically from this person to sign off for second stage full dilatation serial section. For the learning plan, I can suggest to that person to read certain typical other serial section conditions, maybe serial section with breach, maybe, you know, serial section of this condition, serial section of transfer, serial section for second vein, blah, blah, you know. These type of list I can still suggest these ones and, you know, go through to these guidelines. There is that article has published that's very nice actually on the management. That study has published actually, you know, have you read that? So you need to suggest some learning plan and the resources as well to this training. Okay. After that, then depending upon how satisfied you are, then you come to this final part on the first page. So if you're happy to sign that person, then you will cross this second line and you will just sign here. You will leave this line, this trainee performed this observed procedure competently, and then you will sign and put your date, and the trainee will sign and put the date as well. If not, if you think, no, there was something this trainee still needs to work, then you will obviously delete the top line and leave this. Now, when you actually come to this one, particularly in summative assessment, the trainee is working towards competency this procedure, then sometimes your trainees might be fine. They are fine. Most of the time, obviously, they are fine. They know where they are. But sometimes you might have some trainees who, for one or other reason, feel no, they should be signed off for this. And you clearly see you cannot sign them off. But then, no, I don't really need to be. Maybe there can be different reasons. Maybe I'm towards the end of my this particular training year, and this competency is actually the core competency of this. I can't progress to the next, you know, year 3 maybe, unless I have done it. So I really need to get it sorted. I was off sick. That's why I couldn't, you know, I was off for such a long time. That's why I couldn't. But I promise I'm going to make sure I'm good. I'm actually very good, but today my hand is injured. And that's why I couldn't show you how good I'm actually in not dying. Anything else, you know. But obviously, if we are not satisfied, even if I know, yes, this person is, but because this was a formal assessment, it's just like an examination. So if that person is not able to perform on the day of examination, whatever the reason was, unfortunately, we cannot sign that off. We cannot pass that person, right? So what happens in that scenario then? How we deal with those? So let's go to this. Okay, let me just go for a normal one. This is the area in which we were doing. So say, for example, this is like...
Dr. Safi, I just want, sorry to interrupt you. For summative assessment, we are sure that we need to book an appointment and it has to be a pre-planned meeting.
Yeah.
But for the formative assessment, is it necessary that it's always be a pre-planned meeting?
Okay, well, I was coming to formative after this, but we can actually touch here now. So for the formative one, the formative form is slightly different. Everything is fine, the same. It won't say encounter requested in advance. Okay, so that means that person actually didn't need to book particular session to say a list and to request to come with you on the list to show you this competency. But still, the formative one, so say, for example, I'm on the floor and she's on the floor as well. So, for example, she's going to do this salarium section and she feels that she's good. She can have, you know, one of these 3, with a minimum of 3 procedures. So she feels that actually I can get this signed off from Dr. Jubain today when she's here, because she's going to be there when I'm going to, or she can even ask me, you know, say I'm in my office doing something and she comes and say, well, Dr. Jubain, I need this being done. So can you please come and, you know, do my assessment, formative assessment. So as long as she has actually told me before doing the procedure, so that I'm also consciously able to focus on all these assessment criteria, right? So for that one, at least she needs to tell me before she starts the procedure. It can be last minute. It may be straightforward. She feels actually this head is high. It's going to be simple procedure anyway, but I'm going to do it. But before she do it, she come and ask me to say, can you please assess me? Then it's fine. So I will then see her doing that cesarean, whatever, and exactly the same, we will complete all this stuff. And if I feel she is fine, you know, but in that one, you will not have the, yeah, so you will still have the two options here. Okay, this trainee performed this observed procedure competently. If I'm happy, I will delete this one. But this form is say formative assessment. Okay, this is I think old form I have, but the formative one says formative. If it doesn't, you can write down actually formative assessment form. Okay, or you just simply can say no, you need to do more. You know, it's fine. So they usually don't put the formative ones. It's usually the summative will be put in the exam, but it can be a situation, you know, just like as you guys have this one episode scenario in the last exam. So this trainee has, you know, sutured episiotomy, and there had been some bleeding as well at the end, and the apex was not sutured. So there was a lot of notes outside. So you can add if there is any additional information here. So as far as I understand now, different people actually posted me this query, but one thing nobody is able to tell me. So this person is asking you to sign the summative assessment. And obviously because that person was not able to do suture the apex, you obviously can't. And this person hasn't, not only because he was not able to suture, obviously he was not able to suture, and for that reason, you're not going to, even on the formative one, you're not going to say this trainee performed this procedure competently. You still going to keep this one. But then I think that trainee just said, okay, can you then at least sign me, you know, do this observed procedure competently for my surgical note? Because that I have done very nicely and competently. Now, in that one, as long if that person actually, before starting doing that episiotomy and doing this suturing, if I have observed her directly, basically, not from just the midwife notes, or because he's telling me, if he actually called me to say, come and please observe me when I'm doing this, because I would like you to assess and sign my competency after this, then I can do, for not time, I can do formative. If I was happy, yes, that's right, he did not absolutely the way it should be done. Okay, but if he didn't actually tell me before, or I haven't directly observed that procedure, it's just the notes in the midwife, then I'm not going to sign it off, right? Because I'm not able to then, you know, apply this all criteria to see what went right and what I have not been able to objectively observe it. So if we both just happened there, and that person was doing, and then he said, like, can you just, you know, help me just to pull the vaginal walls away when I'm suturing? And then he finds, oh, well, actually it went very well. And she's Dr. Jabin, no, you have seen, can you sign me off? I won't, because I was consciously not doing this exercise when he was doing the procedure, right? So now the people who had that scenario, can you guys tell me that basically what the real scenario was? Was that person asking you to sign the summative assessment or the formative assessment?
Summative, it was summative, Dr. Safia, and he was very rude, and he was not listening to the, you know, the doctor who was candidate.
Okay. So
So
I
he
come to
was
that.
just keep on asking one thing, just sign it, and I want that to
Okay.
get
So I
signed.
come to that in a minute. So the scenario details which were written on the scenario or on the wall or whatever, did they say anything that you have observed for formative, or what was the scenario written over there? Tell me that, please.
Exactly, it was not my day. I discussed with the mom. She said
Okay.
it was outside. Nothing was written. Just the scenario, the situation was elaborated, and inside there was a form.
And what was
And
the
it was
situation?
written summative.
Sorry.
It was
No,
written
Sachin, I'm going to
summative.
go back again. What was the situation written outside?
Situation was that one trainee is there. He did last night. A delivery was some delivery was conducted. He conducted delivery, and there was episiotomy. It was difficult for that. Apex was difficult to take, and there was excessive bleeding, something like that. And then that the patient is okay, fine. Then now he was there, and he was
Okay.
asking that the last night the delivery which I had, I did the episiotomy. I'm here to
Okay.
sign this summit.
Okay. Okay. So it's okay. So, and then during the conversational stuff, did you establish that basically you have directly observed that person doing that episiotomy? Or it was just he's coming, you actually haven't observed, and that person is coming to you now, say, I have done nicely, can you sign me off?
No, I'm not.
Anyway,
I have no idea.
so for future now, so in this particular scenario then, so if the notes already say that the apex was not, you know, suture, blah, 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 then obviously you're not going to sign even the formative one. And even for the knot one, even if the notes say that the knot was done, you need to establish first that were you there actually, have you yourself seen it? And it's absolutely
So he was
fine then
saying,
basically.
He was saying that you were there. So it
Okay.
seems that she was there.
All right. Okay.
But
Okay.
what
That
she
means you have
saw and
observed.
what state she doing, that
Yeah.
was not clear.
That's fine. That's fine. So that's what I wanted to know. So that's fine. So you have observed that procedure doing. In that
Yeah.
case, so you will tell that about the apex and that I can't do that. For the knot, you can start first. So you don't need to say straight away anything. You can first use, all you need to do is you need to start doing this, right? For both procedures then. For episiotomy, so it means technical ability. So you will say, obviously, technical ability, he wasn't, technically able to do that, right? So you will say, was not able to identify and secure the apex. And as a result, obviously, there was hemorrhage, mild hemorrhage or bleeding and needed intervention. So that's what you will write down for her. For this basis, then obviously you will say, you will still do the rest one. Yes, your tissue handling was fine. You did it in the appropriate time if you feel whatever the notes tell you. So completion of task was as appropriate. No, it wasn't. So the task was not completed, right? So here you will write down was not able to complete the task because of missing the apex. Communication with patient or relatives, that you should be able to, or scenario should say that one, you can do that all. And then safety considerations is, when that person was not able to do the apex, did he identified himself that the apex has been left and patient is still bleeding? Did he ask you for help? That's the safety consideration in that particular scenario. So if he didn't, and he wasn't able to do the blast, so then you need to write down as well that failed to identify that the apex has not been, secured and hemostasis has been secured. So these are two most important things and that person was not able to do. Then you will still continue. You won't say still anything here that you haven't been able to do. Then you will ask the person, I say, what went well? Let him tell. What could have you done better? Let's see if we still talk about anything about the apex and anything what, different or whatever. Talk still about any module given on the episiotomy, surgical skills course, and all those resources, then come back over here on this side of the page. And then say, because of these, that you couldn't do that and you can complete that, I feel you need to continue to work towards competency in this procedure, right? No, when you say that, no, this person is going to flare up. No, I have done it, blah, blah, blah. I need to get it signed, and no, you sign it. So then you need to ask by saying, okay, so you are in training. You do understand the prerequisites and the regulations of the completion and assessment of training. And you still are not agreeing and you feel you must be signed up. Is there anything else going on? What is bothering you? What are you worried about? Why are you so stressed today that you must get signed it off today? Okay, so ask that person first. That's the routine standard procedure. Then that person will tell, maybe say, I have been already long, I have been doing this, and then you can say, I can see, right? If there is a genuine reason, that person is lagging behind, basically, he was off sick or blah, 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 and for team reasons. And I'm really now the end of rotation and I'm moving to the next rotation and I can't move to ST3 unless I get signed these up. Then you can say, I can see clearly it is quite stressful for you. I can understand your apprehension as well. Okay. However, at the same time, it's very important that you are actually able to competently do this procedure before you get it signed off, because signing this off means that I am actually giving the evidence that you are actually able to do this procedure independently, right? However, if you're not able to do this, and there can be even more difficult and challenging circumstances or situations in this particular procedure. So if you're not able to, that means the patient's safety will be seriously compromised. So I'm afraid, I feel, you still say, don't say I'm not going to sign, still say I'm afraid. I still strongly feel that you need to continue to work towards competence in this procedure. Now that person, if still the person keep going, whatever, then you need to know the second step further ahead. You need to go become a bit more assertive now to say, I think as your supervisor, as your assessor and trainer, it's my, legal responsibility as well, because of the responsibility I have regarding the safety of the patients. It's very important for me that before I actually sign you off for this competency, I'm able to actually demonstrate that I have seen you doing all these steps competently, and it's safe to leave you to work independently. Okay, but unfortunately, these criteria are not met, so I cannot sign. And I hope you understand my position and responsibilities as well. All right. So I hope that person should understand at this stage. If that person still doesn't understand and keeps saying, no, 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 blah, blah, then comes the third level of escalation. For that, then you need to say, okay, so you don't need to keep going in that discussion again and again. You don't need to sign anything either till he agrees. You don't need to delete anything till that stage either. Leave the form as it is and then say, okay, I feel no, there is a conflict, right? In signing, on this outcome. As the assessor, I strongly feel you need to still continue to work with competency. However, you feel you should be signed off competently. So this needs a conflict resolution. So then you can offer him 2-3 different options. So first you can reassure the first, when you are doing the first step, if she says like, I need to do this and I'm running out of the time, you can say, I can provide you one-to-one support. I can, provide you extra resources as well and give you more so that we can, in next 3 months time, I can push you extra 3 months in this second year 2 training. And then we do this assessment and then I will be giving you one-to-one support as well to make sure that you actually achieve these competencies. Right, so that is for the first stage. So and then stage 2, which we talked about by saying going back again, and this stage 3. Then at this stage you need to say, so you can take it for conflict resolution, and I hope you're aware of the process. If you're not, I can give the information. So what you can do, you can actually get this assessment done by a third, by another assessor. So there's one option, and the second is, you can take it to the clinical tutor for the conflict resolution. So, and then you don't need to sign anything. All you need to then do is, if he says, yes, that's fine, that's what I would like to do, then you will write down that the conflict in reaching the agreement of the outcome. Okay. Then you will say that from my, assessment to complete, I need to delete this because that's my view I need to put on. Then you will delete this one, you will sign and start this. And because you have given the plan as well, the plan is to take the matter for conflict resolution to the clinical director or to the clinical tutor. Okay, you will write that down and he will sign and you will sign as well. And that person then will take that to the conflict resolution. Right?
Dr. Safia, the important then all that is that summative assessments we are not supposed to sign. It has to be ST6 and 7 and more.
Okay. So
how we can force us, or it's a simple, we cannot sign summative.
No,
As far as
no,
normative, fine.
No, so what is happening here basically is, because when you're doing this exam, some of your competencies are being checked as well, like you are working as a consultant. And what you're doing, what are you going to do? So when you will become consultant, before you actually will become consultant, you need to achieve these skills as well. How are you going to do the assessment of your trainees? Okay, so that scenario will say, the scenario will say that you are a consultant, or you have seen, or that person might say you're a consultant, or you've seen it. Okay. So don't worry about that point, because as I said, you could be a post CCT holder as well. Like you have completed your 7 years of training, your training is complete, but you still haven't got the post for consultant. So that's not the paramount and the most important factor, that whether you can or not. It's like for the examination purposes, you need to understand is the assessment that you understand how this assessment is done. And then you also understand and you are trained how the feedback is given in a constructive way so that the trainee actually can take that and accept it. And then if there is a conflict, how will you resolve that? Okay, so this particular station is about this process, this whole pathway. It's not for this basic thing that you actually should simply say, because I'm ST5, I'm not supposed to sign you off. No, all right? That's not the case here, no. Yeah. Okay.
So if he gives us a formative, doctor, and he've done it bad, or I give him some feedback, or I had some discussion, and he gave me a formative, I can sign it no matter what, even if he did it in a bad way, or no?
So if he did a bad way, then obviously that person is not competent. right?
Yeah.
Then you will delete this top line. This trainee performed this observed procedure competently. You will cross this and you will leave this line. This trainee is working towards. So means this person still is working. And then you can give him ideas as well, actually, again, the learning plan here. The how you can, just observe, can observe me or observe this one and ask, when there is the delivery suite is working a bit, lighter, then you can ask actually your SD5 to come and observe you or tell you or show you what's doing. You can watch that video in that module on this one and have you attended your surgical module course, surgical skills course, or go for their surgical skill course and then just do. And it happens, obviously. It's not like the first time they ask for the formative and they get signed up. Obviously, sometimes they feel, but for some reason on that particular day, the things don't go right. And then we keep them still on this by working towards competency in this procedure.
Doctor, our confusion in this station, is it a teaching station or should we perform it in front of him, then we make him do it and then we judge him? Or that's what's the confusion of most of the candidates.
No, not at all. This is not a teaching station. You're not going to actually tell here either how to do it, even if it was a formative and that person needs to improve, that will be done some other time. This is only about this whole process to complete, which I have gone through this. Okay, so like complete this top bit here first, right? Complete this bit here. Okay, this is a formative. Then go on the back of this form here, complete this all. What
Dr.
went well? What went? So you're not teaching anything. You're not going to actually tell here how you should do it. That you will book for some other time to say. As I said, in the learning plan, you will say, we can, arrange another session. Next call when you're working with me or whoever you're working with me, you speak to that consultant or your supervisor so that you can observe some more cases or you can be supervised for some more cases. You will give the plan, but you're not going to tell what are the fundamentals and regulations and how we suture the result. This is not teaching station. No, this is assessment station. OSAR's assessment station. Simple.
So the formative, we will say it's bad or not or good, and the summative, he's done it well and it should be done by consultant and something like that. That's why we got confused.
Okay. The
Dr.
formative and the summative, you don't worry about, you don't need to say that I being SD5 cannot do this. Okay, first thing, forget that. You assume you're a consultant basically. That's why you're given this assessment to take place. You don't say good or bad either. I'm repeatedly saying these two lines here, this trainee performed the procedure competently. That means if you keep this line, you are signing off this person as a competent. You don't need to add from your words by saying this person is good in this or competent. You don't need to do anything. Just cross this line, keep this top one and sign in front of here. All right. The feedback is also a logical planned feedback which you will give there, and the trainee will tell first what went well. You will add that this was done when what didn't go well. That's it. You're not going to give generalized comments by saying yes, this trainee did very good. If you're saying something has done good, you need to say what particularly has been done good. Tissue handling was good. The NOT technique was good, right? It chose the right instrument. He chose this. He was able to identify the bleeding. He was able to skewer that hemostasis. It needs to be proper. Okay. Anything else?
One question, Dr.
Dr.
Safia.
Yeah.
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 Okay, Samah, you ask, then I will ask.
Okay.
Okay.
I have some question. First of all, if formative and the student or the trainee is incompetent or working towards a competency, we will fill the form like
Yes.
we will take scratch on the he is observed and leave this work
Yes. Yes.
to competency and write what is went wrong and why and what is some people tell
Yes.
we will leave it blank without any signature
No.
and tell him no, we cannot sign.
No, they people are telling you wrong, unfortunately. So whatever,
So
I
we
mean,
have,
you are okay. You are not coming to this column anyway. That's why when you will re-listen this recording as well, what I told you is you will first complete this irrespective whether this person did good or bad. You're going to complete this portion. Then you're going to flip over the page and come on the other side of the page and complete this irrespective you are going to sign off or not. You still need to comment, because even if you're not
So we
signing
have
that
to
person now
inform.
incompetent, yes, you need to
Yeah.
inform that person. You need to document and also tell him what to improve. If you're not doing
Yeah.
it, how the trainee will know what didn't go well and what he needs to improve, right?
Okay.
So you're going to
Yeah.
do that irrespective what the outcome will be finally. You're going to do that each one by one. Then this feedback went well. Then you will come on this one, right? So this one, you're not going to complete this. This portion needs to be
And
done at the,
for these areas,
this one here. Okay. This one needs to be done at the last.
Yeah.
Yeah. Is that
Yes.
clear
And
now?
we will sign our name. We will sign our name, and he will,
Yeah.
will tell him to sign his name also.
Yeah. Yeah. Yeah.
Even he is not competent.
Yes.
Okay. And for these areas for competency, these topics about the safety and documentation, shall we will put ticks in front of each or across, or what we will write in this
Right,
table,
okay.
the other page?
Yeah. Let me just go to that. So we're talking about this, yeah? So it's not the cross of the tape. You basically write down something. So you will say checking equipment environment. You will say up to standard, satisfactory.
Okay. We will write
First
down
table.
some words.
Yes, you need to short note. So upright, you will say up to standard, satisfactory, up to expectations, right? This one as well, up to expectations. Safety
And
consideration,
if about that,
yeah.
Or unsatisfactory.
Yeah, or you will write, when you say unsatisfactory, then you need to tell what, right? Say, for example, completion of task as appropriate. So I will write down not completed because the apex was not sutured or was left unsutured, unable to identify the, then you need to briefly tell the reason as well, what not, right?
Okay. And for the how many formative it will be? Must be 3 to go through the summative.
Minimum, they need to have 3 signed off as as this top line. The trainee performed this procedure, so they need to have minimum of 3. It says here
3 formative.
Yeah.
Okay.
Yeah, it says here. Look, trainee requires a minimum of 3 procedures deemed competence per core procedure by more than one assessor, and those all 3 needs to be signed by 3 different consultants.
So it means, Dr. Sophia, for cesarean section, it has to do minimum 9 cesarean sections, because 3 by 3, isn't it?
No. Total 3 signed by. He might have ended up actually doing 10.
No, but those three observer at the same
3
time will
needs to
see and
be
sign.
competently. Yeah, 3 needs to be by competently, and there needs to be by 3 different consultants as well. So when he was asking you, basically, if that person says, sign my summative. So let's say for so episiotomy, we said you need to work towards, but the knot, he said, I did the knot very well, and because there is a separate OSATs for the knot, can you sign that off for me? Then you need to say, so although I'm happy now from the knot point of view, first I need to know, check these prerequisites. So I will say, okay, I can't sign the knot as a summative either, because this was not signed off in advance. And second, I need to see your minimum of 3 formative assessments for the as a competent for the knot tying. These are 2 reasons for which basis we will not sign her as a summative on the knot tying either. But yes, you can do this. This trainee perform this observed procedure completely, and you will write down the name of the procedure here, the surgical knot tying.
Okay, and how many summative OSAT we have to sign, or the trainee have to sign?
Yeah, summative is only one. Yeah, summative is only one. But then we, for different procedures, we mutually agree. Then, like there will be another assessment maybe after 1 year or after 6 months or something like that. But for the former, for them to sign off and move to the next level of training, it's only final one summative assessment. In simple words, You guys need to assume the summative assessment basically is the examination. Okay.
Yeah.
So
And
they have to pass it to go further. That's it.
yes,
And that's only
if
once.
And Dr. Safia, if like he refused to sign, like refused to sign the summative because he did not sign formative before, and then we tell him, he will tell us like, can you sign this formative OSAT for me? Can we sign that time?
Sorry, say again. There was quite echo. I couldn't understand you.
So if like the station of the episiotomy one, he did not do any formative OSAT before, and then at the end he said, "Can you sign this summative for me?" So
No.
we'll tell him that we cannot sign it because he did
Yeah.
not do formative. Then he will say, "Okay, this is the formative. Do this for me. Can we do it?"
Yes, for formative you can say it can do if it's done nicely, it's done right. You know, then you can make him to read this. This is written on the forms. You can see, you know, you need to have minimum of 3 formative assessment first, and then we can do only summative. And the other reason for not signing up summative is that he has not, the first, he hasn't fulfilled the criteria anyway. He needs to have 3 formative assessments. And then even if he had the 3 formative assessment, he was supposed to request us in advance. Okay.
Okay. Okay. Okay. Thank you.
so, Dr. Safia, if he requests in advance and he has 3 formative OSAT and he tell me to sign the summative, I will go through the summative like I went through the formative now. I will see if he is competent or working toward competency, and I will fill the form.
So form is same for both. This is this form you will be doing for both. So the same steps and
Same
everything
steps.
same. Yeah.
But suppose
This
he
is the form
request
for
in
both.
advance and
Yes.
he
Summative
has 3
book in advance.
formative.
3 formative beforehand. Yeah. 3
Okay.
formative signed as being able to complete the procedure competently. Yeah. Trainee performed this other procedure competently. 3 of these formative and booked in advance. Right. Are we okay to move next now?
Yes, thank you, doctor.
Let me see the messages then, people. 3 summative forms to be deemed competitive, Dr. Sundars. No, Sundars, 3 formative forms need to be, if they are, then you need to do the summative as well. So say he already have 3-1, but it's not, then yeah, okay, so Sundars got it already. That's fine. Anybody else? I think we have explained, the BG has similar question as well, so I think we have explained it now quite detailed. Right, let's move to the next thing now then. What is risk incidence? This is nice and short and brief. Okay, so I actually had, we went into detailed discussion, and so how we basically complete that one. So you know the example I was taking along with regarding the second stage cesarean section. So for second stage cesarean section, as say for example I was doing how we'll do, so I will comment on these first for summative or formative, whatever. Yeah, I will say that. And what went well, what type of statements actually can be written over here. So these are this is how you will write on. So you first will ask the trainee what went well. The trainee will tell you, and then this is how you will write down. You will say the competent assessment of difficult trial of instrumental delivery. So the scenario was basically the patient was first trial of instrumental delivery in theater, and that was unsuccessful, and then he did the second stage cesarean section. Okay. So you will say, okay, the assessment of difficult trial of instrumental delivery in theater with backup. So that was really well that he assessed that he should do this trial in the theater, and he already made the preparation and the consent for cesarean section in case that fails. So this was the preoperative planning. Yeah, so I'm happy with that he was able to actually work on that. Confident surgical approach, good technique to disengage and deliver low hedge. So you can't just simply say it was well. You need to then tell what particularly was well. What are you saying is good? Prompt identification of extension of uterine incision and satisfactory hemostasis. So although it resulted in the extension of the incision, because of that, I'm not going to say, no, you're not, because we know it's one of the known complications of the second stage. It can happen with very experienced hands. So what important is to assess that he was able to, after delivering the baby, he immediately checked whether the incision is extended or what has happened. Then he was able to secure the hemostasis as well. So as soon as he was able to do it safely and nicely, that's fine. I'm happy with that. Proactive approach, like beforehand planning to prevent the risk of EPH and active stage of management of third stage. Yeah, so this is how, say, you will write on what went well. Then the example of writing, what could have been done better. This part on the form. Yeah, this part on the form, what could have been done better. So that one can be commented something like that. Although I was happy I signed him off, but then could disengage and push head up in the pelvis, forming failed instrumental attempt. So he did the instrumental, it failed. He just delivered the head, he did the cesarean and delivered the head from the top. So, I routinely do, if I have done the instrumental, it's not when I, put the instruments away, I try to disengage the head and try to push it up before I proceed for the cesarean section. Because by traction, we have further engaged the head deep into the pelvis. So obviously then it's going to be difficult now from the top, and there will be more risk of extension of the incision. So push it, and then, the guideline of second stage also suggests that now. And help of experienced midwife, and the second is, you did that beforehand, but because the patient is still having the contractions, the head can be pushed down again. So at the time when you're supposed to deliver, you are going to trying to disengage the head from the top. I always have used, one of my senior midwives to basically to tell that in a flex position, try to push the head upwards at the same time. So she disengages, because you can't apply too much force to do the curl, so you just make a bit of combination. This decreases the risk of uterine incision. So although, incision happened, and I feel you could have done that, but that just is like what you feel comfortable. Some people then decide to deliver the baby bottom first, and it's fine if they are comfortable with their technique. So that was just a suggestion. He could do that, but that was not something which resulted in a great hemorrhage or things like that. So I can give the suggestions, but I'm happy to sign him up. What further learning I will suggest: to read possible complications of cesarean sections for various indications, and prepare personal list of pre-planned consideration of these as well, like just a little exercise, conscious exercise. What I need to do, if I'm doing late second stage, what I need to keep in mind. If I'm going to do the bridge cesarean, what particular things I need to pre-hand, plan in my mind, and things like that. All right. So that's all. This is you put those feedbacks, these type of statements you use. Okay. So we are going to now MDT reference.
Dr. Safia, I just want to ask one question.
Yes.
Yes, Dr. Safia, when we enter in the cubicle, then how will we start that? We will ask from that of the ST1 or the candidate that what gone well, what you did good, because we haven't seen the procedure.
Right. Okay. So as Adila said, this when you went in, basically you go in, you will say hello, because it's your colleague and the name is given already. You will call directly by the name. So say, for example, there was a, Dr. Sama. You go in and say, hello, Dr. Sama, I'm Dr. Jalene, one of the ST5s, and then you will just sit down. So just the routine, just imagine you're on the floor really talking to one of your juniors. And then you can say, okay, so, how long have you been in this unit and your training now? And then just check by saying, so how are the things in the unit? Are you doing okay? Are you happy with the team and everything? Any problems are you having? And just in a social way. Any problems, anything you're struggling with? And then you say, because you know that scenario already, then you can say, okay, so I can see you have performed episiotomy last night. And you want to discuss something about it? Yeah, at this stage, this is all you need to say. Let him say first now what he wants to do. Unless it was given outside already that you need to sign this, and then he will say, right, yes, I did it, and you were with me, you have seen me doing this. So when he says you have seen me doing this, then you will assume you have seen it, and the findings which were given in the scenario outside, which say there was a bleeding and he was not able to identify the apex, but he has done his not very competently, that you will take, that's your finding, you have seen that happening. Okay. So then you will ask her first, okay, so I understand you want to discuss about the episode you did last night, and then ask him, so what you want to discuss about it? And then he will say, okay, so I have done this and you watched me doing this and I want these summative and the formative or whatever needs to be done. So, and then you will just establish the talk as we said. Then if he says it was a summative assessment, I want you to sign a summative assessment, then you need to check the first, as we said, the first thing, did you arrange this pre-hand? So first, very important, basic thing to start, you will start completing this form and this column here. So write the trainee's name, trainer name, procedure, and that, because we can take it as a formative. But be careful now, the forms I think do say formative assessment form and the summative assessment form. Okay, so make sure it's the formative one. It can't be, summative, as we discussed 2 reasons already. And then you will just go, and you will explain what is the purpose of this. You will go through this line as well. Trainee requires a minimum of 3 procedures, competent per core procedures. Then you can say, so have you actually have already signed off 3 formative assessments of competency? And do you have those with you? Because obviously you need to see them. Okay, and then turn on the other side and start doing the rest of the exercise. Okay. Right then, so MDT, multidisciplinary referrals, is something else, again, from documentation point of view, and this comes under documentation and colleague communication categories, and it's very important. Now, whether these are the referral forms or they are discharge letters, there needs to be comprehensive. Comprehensive means they must have the clear information and all the important information your other colleague needs to know about that patient. That means comprehensive. And brief. Okay, so brief means there are so many patients the GP is sending to the doctors, not only gynae, to medicine, I don't know how many more. And even in MDT, there are so many other referrals as well. They don't have a time actually to sit and read, pages and pages. So it needs to be brief as well, usually on one side of A4 paper. Okay, and for that reason, to make it standardized and also to make sure then that whoever is doing, there is a consistency in supplying that information to the colleagues. In these particular type of situations, we do have these performance. So every unit basically have standard performance. So whether it's a senior person or a junior colleague who's doing, they know they need to answer these at least, as a part of the information they need to send it to. So I have this one of these. So these usually the performers, they usually look mostly are like this. They might be just a little bit thing up and down. So on this side of the, you will have the name of the trust and your unit, those details and the address. This side will have the details of the MDT meeting. So lead clinician is the lead clinician or their supervisor consultant, your consultant, whoever that is. Then MDT team lead. So and then again, in obs and gynae, or overall, you will have your MDT and you will have a named person who usually is a gynae oncologist consultant, oncology consultant, right? So the name is usually given there as well, but they are always given unless they are changed, and these forms change as well, because you need to know who this information is going to. Lead specialist nurse name is there as well. Now, it's not necessarily that you have this MDT team only from your gynae. It could be just the trust overall, so it could be one of the consultants or one of the oncologists, general oncologists. Gynae oncology coordinator, they are usually our medical secretaries. Yeah, so and the reason for them to be the part and their name is because these are the people, when you've completed this, you're going to give this to this secretary to fax it to this team for discussion in the next meeting. All right, so obviously she needs to be there, and then she will also make the note of the patient details and everything, so that when we are seeing there, if it is a hard copy, the notes, then she needs to actually on that day take all those patients' files with her in that meeting, because I might be coming straight from theater, you might be coming straight from clinic.
So she will be taking all these notes of these patients. And if it's online, then she will have actually the list of those open on her laptop for us to approach. Again, I might be coming direct from theater and don't have my laptop with me to open the patient notes. Okay, so that's the reason. Then this much part is pretty standard as well. Just again, common sense thing. So you need to obviously give the details of the patient who are you want to have the advice. Yeah. So name of the patient, date of birth of the patient, name of the consultant she's booked under. Okay. And this is must. The reason for that is because this is a consultant who will be, in case that consultant herself or himself is not present in that meeting for any reason, I may be on annual leave that day. Okay, so if you don't leave that name there, then who is that feedback basically that although your trainee will trace that as well, but as a consultant, it is my responsibility that I actually make sure, although you as a ST5 are talking everything in there, but on the top, then as a consultant, I'm doing the same exercise as well to make sure this patient is not, missed. What has been the plan and how are we going to execute that plan? Have I seen the patient, right? So name of the consultant is must. 2-week waiting. So it's 2 WWs, 2-week waiting. Like, is that patient an urgent MDT referral? The MDT referrals can be different. It could be urogyne referral. It could be some other referral, but they're not cancer referrals. So the cancer referrals are suspicious malignancy referrals. You will check that yes. Yeah, yes, it is 2-week. Okay, what is 2-week waiting target date then? Right? Because that's I need to know as well. The team needs to know to put the priority of discussion for this particular case. So obviously the waiting time is 2 weeks, and that 2 weeks from the point when the GP saw or somebody saw in gynae OPD, so whatever initially, and then they said I'm going to, when we say I'm going to make your urgent referral to be seen within 2 weeks. So by the time we saw, from the GP referral came to us, there was already 1 week gone. We saw at the end of first week from that initial date when the GP saw. So that means that there is only 1 more week left. So you need to write on that target date as well. So say, for example, that patient was initially seen by the GP on 14th of February, right? And at that stage, the GP started the fast track referral. So the target date of 2 weeks for this patient to be seen or to decide this management plan will be 28th of February, right? So you need to write on 28th of February here. So in case, if it's already 24th of February, then we know this patient has target time left only for 4 days. So we need to discuss this patient on a priority basis today. And why that is important, the priority, we need to decide the priority. Now, these MDT sessions, they are usually again 1 session per week. So 1 session is 4 hours where this team will meet. And then there might be 10 cases, there may be 12 cases, there may be 8 cases to discuss to make that plan within those 4 hours. So for that reason, it's very important. So we may not be actually able to complete all those 8 cases that day. But what is important then, if we have the target date, the people whose target date is fast approaching, we can actually prioritize and discuss them in the beginning of the meeting first, so that even if we run out of the time, at least we have done them. Okay, so that's why it is very important, why that is important. And that is again a national target we must meet. If we don't actually meet our target dates, there are 2 things. Number 1, we have compromised the safety of the patient. We have compromised the quality of the patient care, right? Which is very important. And the second, for doing that, no, we will get penalized. The trust will have to pay a penalty for that. All right. So that's why these things are important. So this is how you will complete this part. Then this will be GP details they have written, because this is referral from GP, but because you are making this referral from your, but you will put the GP details as well. So you have given your consultant referral here, details here. You will write on the GP details here as well. The reason for that is any communication we will be doing from after this meeting, they will be sending a letter to me. They will be sending the copy to GP as well to keep informed. When we say I'm going to write this out to your GP as well. So the GP is not actively going to do anything at this stage, but later on GP will be involved. So let's keep the GP informed as we are going along. So GP know as well what's happening to his or her particular patient she has sent up. All right. So there you need to have the GP details here always, so that letter can go to GP as well. Reference information now. Okay, so most of the forms, you can write on this format. If no, I don't know when you have done this, have they given you the referral forms there? Or they just simply want you to tell what needs to be included? Then obviously you can even make, this type of thing, that this information needs to be done for patient, and then for the GP address. So there will be GP name, GP surgery name, and GP address, and the contact phone number of the GP. And same way, your consultant name, your own unit's contact details are given over here. You can you can write on your phone number as well. The contact details are important. Then the summary of, so how are you going to give the information? Okay, so summary of patient history, and that needs to be brief. Okay, you can't go into column, but the history means you must give the important salient points of the history, right? So say, for example, we take the vulval cancer lady example. Then you will say vulval cancer. You don't need to write down the history of itching and soreness and blah 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 for last 6 months. The biopsy has been done already. Biopsy have shown she got the vulval cancer 3 or whatever from the the finding or examination. We can give some initial idea. That's just a provisional one. So you can say this carcinoma of vulva. So you will write down, say 54 years old woman. Yeah, 54 years old, diagnosed with vulval cancer. Whatever the biopsy report is, which says this is carcinoma. And then you will write down the area of involvement you can give, because extent is important. And the histology report you need to give all, if they have described differentiated, poorly differentiated, or whatever, you will write that down. Then you need to add the comorbidities of the patient. Yeah, and then you need to say as well, like it's a first presentation or if it's a recurrence or what that is actually. Yeah, so you need to give that bit of clinical history. Then you can give a brief idea about having this for 6 months. Whatever the age, post-menopausal or pre-menopausal. Menopausal, this contraception, again, the important thing is yeah, contraception, this cervical cytology negative, no family history of column of family history. So you need to give family history, in every scenario, family history of breast cancer, ovarian cancer, endometrial. So you need to give that here as well. Then comorbidity, your medical history, medical or social history. So medical one, again, just brief. Say, for example, this medical one has diabetes and hypertension as both. You will cite as diabetic. And then about this as well, and stuff. It will depend, overly controlled. I would inform that to the team. Performance status is usually like, the initial kind of staging grading, which we feel from our clinical examination and histology. Proper staging will be done in this meeting, basically. Okay, so this is up to here. You need to give that information. Now, comorbidities and the history, I will say add one heading here as well, investigations. Okay, they have put it down here, radiology findings for you to write down, but instead of keeping, because this part mainly is for the discussion of the MDT meeting, so I will say you guys add the heading of investigations here. Okay, and in the investigation, again, just the relevant ones, right? Radiology, so you can write on what if there was any ultrasound scan finding or CT scan finding or chest X-ray, if there was some positive finding. Okay, so you can write that down. If in full blood count, there was anything abnormal, you can say anemia or something. Otherwise, you can write down full blood count, LFTs, UAEs, RFTs normal. Yeah, because she's hypertensive, she's this, it's one we say that is normal. But if something is abnormal, you can write on anemia, hemoglobin 8.7, just the iron levels of this. Then performance stages is just most that is fine if you even don't mention this. This is not a major deal. Okay, but this particular obviously department that you have that as well. But this basically is not mandatory for you to write down. Family history obviously is, and if there is, don't say nil family history or no significant family history or no family history of concern. No, write down no family history of CA, breast, ovary, endometrium cervix. So talk about all gynecological and the breast cancer and the bowel cancer, say it's ovarian cancer you are sending for. Points for discussion. Write the main question being asked and what needs to be reviewed. Scan histology or notes. Now, they will discuss everything. They will, but then still, you need to put here as well for them to focus and consider what particularly you want. And additionally, is there any, any other question in your mind? So say, for example, in our vulval cancer lady, there is very extensive cancer. And then she said, well, quality of life is better for her. She, she would like to stay as much acne-free. It doesn't matter if she doesn't live another 10 years. She's happy to compromise, but she doesn't want to go into what that piece of information gives you ideas about. This patient wouldn't like to go through the lot of morbidities and the complications of the surgery or the other treatments, whatever, she would like to keep a balance in between. So whatever the patient wishes, you need to write that as well. Or you need to ask yourself, say, for example, the other example I will give one of the scenarios where this woman is 32 years and she wants to preserve her fertility, and she has complex endometrial hyperplasia with atypia, right? So in that particular woman, we still need to do MDT. So you need to write down, atypical in this histology report. You will write down, atypical hyperplasia, and you will give this one all the details here, the date and nulliparous, contraception, whatever, condoms, comorbidities. You can say, no medical conditions. Family history, no family history of these cancers, and points for discussion are, you will say, so nulliparous wants to preserve the fertility and have the marina coil. You will give the marina coil used as well in the top one, marina coil with no success, blah blah. So then you will say, want to preserve this marina coil didn't, if she has been used previously, was not effective, and if not used, then you can say need the management plan accordingly, keeping in view her fertility requirements. Okay, that will be your question. So then they will discuss, do the staging, say CA vulva, come back to CA vulva case. They will do the proper staging now from histology point of view, from clinical. They have the radiologist with them all together. They will assign it a formal staging to that cancer. And if they have to give any further comments on the radiology findings, or if they want to have some more scans done, maybe that can come here. Then MDT plan of action. Okay, so plan of action will be, again, if they want further investigations, some more investigations, do these, and then they plan. Okay, just like for the vulval cancer, sort of like the radiotherapy is the best option for that because it's an extensive cancer. So the radiotherapy will be a good option rather than surgery. And that's the MDT plan. We will go further than what happens when you come with this plan to the patient, who to describe that to the patient. Okay, and that is the plan made by this team together, keeping all the information in mind, that they feel this plan is the best safe plan in the best interest of this particular patient. But it's up to the patient then whether she wants to agree with that plan or not. So don't get frustrated if you come with the MDT plan and speak to the patient and she's not agreeing. First, ask her, as we say, is there anything else which is concerning you or bothering you? And if there is no other reason, she simply doesn't want to go ahead with this, it's absolutely fine. No treatment is also an option, okay? They are giving us the best plan suitable for that patient, right? But we know from our other approach that this is the best treatment plan. This can be alternative plan, say surgery, but surgery will have blah 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 these, and even for the best plan you also need to do what it involves, what will be the complications, and what will be the outcome. Alternative is, even if she is happy with that, you still need to briefly tell about the alternative as well. Surgery can be done as well. However, in those cases it may not be very suitable because the cancer is so widely expressed. This will involve a lot of tissue to be removed and these complications, right? No treatment is also a plan. All right. And that's your name here, yours sincerely, and whoever you are, your title and your contact details as well. So don't forget to write your phone number or bleep number, because sometimes they just quickly need to, there's not much time that they send you an email or something to ask if they want further information. So you must write down your bleep number or your phone number here as well. So full name, printed name, your grade as well, SD5 trainee, Obs and Gynae, and your contact number as well. So if you need to ask you anything, they can ring you and ask further information about that particular patient. Right. So we have Okay, so these were the two brief some information about, I think, a couple of scenarios which have come back in exam. Obviously, I think this is not complete information, but anyway, this is 70 years old, postmenopausal bleeding. Name was written, fast track referral, ultrasound finding, endometrial biopsy showing adenocarcinoma, asking for surgery. So you know you can see what information you can add and what more information you need to, right? So you just need to simply then start viewing this all. Has the details of that unit given here? Which unit this patient is getting sent to them, and what is the contact details of that unit? This team, you know, who it's going to, their contact detail, emails, the GP detail, have that been given for that patient on the top of the form, even if it's not a printed pro forma, right? Have you given the patient full name, surname, date of birth, hospital number if the patient has, if in the notes it's given, right on the hospital number, consultant, full name, printed name, and then to whether this patient is a fast track, and then obviously this is fast track referral, yes, and target date. And then the information here will be 70 years old, postmenopausal woman, you know, from your these details. But and then look into the notes as well, what else is given there. Yeah, so she has postmenopausal bleeding for how long? 4 years, 3 months, 1 month, 2 months, 1 episode or 2 episode. And then you can write an ultrasound finding, maybe thickened endometrial, you know, no, the biopsy shows adenocarcinoma. But there is more information we need as well. It's not all enough, yeah? Then you need to look into the notes, as we said. So you will write some details here. Then look quickly, does she have any medical conditions, right? And what else we need to know? The family history of these cancers. Were her smears done normal? When was the last smear? Was that normal, right? What other medication she's on? Has she previously have any history? So you can write down, you know, she has this and no previous history of cancer, this contraception she has been on in her life, this BMI is very important to tell in any reference, yeah? So write on the BMI. And then comorbidities, your next heading, think about, check the notes quickly, has any comorbidity and medicines given, then must tell as well whether it is controlled or not. Performance stages, forget that. Family history, even there is nothing you need to say, there's no family history of that. And then points for discussion. So the points of discussion is that question, what is appropriate management, you know? So come on, this one here. So asking for surgery. Yeah, so 70 years postmenopausal bleeding in carcinoma or surgery, okay? So you can ask this question, you know, is surgery suitable treatment for her? It's a simple question. I mean, they know they're going to discuss that anyway, but they just want you to be very clear in case if there was something other than usual you want to know, or was there anything different which they didn't know? Say somebody can be 45 or 46 years old or 48 years even old, and she has complex hyperplasia with atypia. Somebody, you know, overall you might think, unless you write down this woman does not want, you know, the uterus removed, whatever the reason. If you don't put that, we are going to think, well, she's two years away from her menopause. You know, so I will give the plan, you know, total abdominal hysterectomy with bilateral oophorectomy. Unless you write down the patient actually refused for this, a patient doesn't want to or something, then we can consider some other options. Okay, what other options can be, right? And that's why it's very important, this question here, what particular question. Or you can ask something about the histology. I mean, you can ask them to give us the staging of this or more information about the histology, because your histopathologist will be there as well, yeah? Or about the scans. And then MDT will give that plan. If they want any more scans done, and then also about the treatment option they think is better option for this patient. So if we come there to our vulval patient, so this is the notes you have basically. So go in the beginning of the notes and quickly read the history admission note of the patient. So Linda Robert, 52 years old, present with squamous cell carcinoma which has spread to 1/3 of urethra. This is the histology report. So on this form, I will write down Linda Robert, 52 years or 72, whatever, how many years she is. And then you will write down, you know, biopsy or histopathology. Biopsy, you will write a squamous cell carcinoma, and then clinically spread to lower third of urethra. And then you will, so you won't write down in the bullet points because there's not enough space, yeah? So you will continue further by saying, write down here histology. Actually, investigations and histology, you can put them as a small headings, basically. I would like to do that, yeah? So 3 more I would add here. So before comorbidity, this is the clinical history. Then write down histology, investigations, and radiology. Give those findings as well. Otherwise, you can just write down in the paragraph as well. So 52 years or this, and she has continuing the same line by saying histology, comma, poorly differentiated. Don't write down a biopsy and all that, just the histology, poorly differentiated squamous cell carcinoma, extend it to the margins. Lymphovascular invasion present, lymph node biopsy shows presence of squamous cell, right? So this in the line, the paragraph, or you can just write down as a histology and just write the histology in 1 line. Then write down the radiology if there was any scan done, write down that one. Then write down the investigations mean, full blood count, blah, blah, blah. These are normal. UNEs, LFTs, these are the basic you need to give them, yeah? Just look what has been done. So from this one, what you will do then investigations, don't write on this way. You will say anemic, HP 8.2. Yeah, the rest is fine. If you don't comment on them, that will assume the platelet white blood cell count is normal. Then you go to write on the radiology. Next to that, you have underneath the radiology, chest X-ray normal, scan, extension to the bladder, and CT scan, extension to lymph node, to bladder and to rectum, right? So these reports will be then attached with those notes as well. Okay, so it's not only you have written, they will review them. The notes will go with as well with this form. Comorbidities then, on the form, you did have the 4th one, a brief here, comorbidities. So you will write on the comorbidities, whatever they are, diabetic, hypertensive, cardiac failure, on treatment, well controlled, in 1 line. Patient wishes, where it says question to be asked, yeah? Question to be asked. Appropriate management plan, patient wishes, and the patient wishes are preservation of the anatomy if possible, and unless she has said something like that, right? And the quality of life gets preference over quality. So maybe, it's not very expensive. Surgery could be a good option for her to start with and then followed by radiotherapy. But she doesn't want to have that disfigurement of the area. She's okay maybe to die in 5 years rather than 10, but wouldn't like to have a disfigurement, of the area. So there can be patient priorities. That's very important to give that plan, yeah. So in the column where it says question to be asked, we said, please guide appropriate course of management to achieve a balance between clinical management and patient wishes. And then MTT plan. So that plan will be written over here, what they give. So the MTT plan was, they said, from that one, it continues there. So on this form where it says MTT plan, they wrote back and sent to us the, whatever, the new adjuvant radiotherapy is the best course of action. And after reduction, you can go for the surgical option. Don't particularly go this 1/3 urethra patient, okay? It's just example. So this is what will come back. So this completes your, you basically are before MTT plan. So you need to basically write down everything up to here when you will go through this presentation later on, right? Then this is all the MTT write down. They will write down on the same form basically, right? So when they are talking, so if I'm in the meeting and I have my ST5 or, we will write down the plan which is discussed here, right? And then the copy of this completed form again, 1 copy will stay with the MTT folder, this meeting, there. 1 will go into patient notes and we will send 1 copy to GP. This is how the communication actually continues. The same, you don't need to have them do separate letters. Just a copy of this now, send it to the save your time as well, and that has complete and comprehensive documentation of everything. Right.
Dr. Safia,
Yeah.
when the question of this MDT, the MDT report is there and you have to explain the report and whatever they have chosen or suggested treatment. So while we are explaining this, so in that station, shall we ask the patient to tell us the previous history or a course of the disease or course of the, I mean, or to start from the MDT report.
Okay, so now when you have the MDT reports, now you have reached to the definite diagnosis, you have reached to the plan of management, right? Now, what naturally should happen from here now? It's not okay in exam. Yes, you are starting from this plan, this point onward, but obviously this is a journey of continuation of care for that patient. That patient was seen, history has been taken many times, examinations done. She has that biopsy, then she has the histology report, then MDT meeting, and she's coming over here. So at this point now, if you start taking all that history again, which is not going to help anything, add anything further anyway, because you don't need that information to establish the diagnosis or anything else, right? And then the main purpose of this 10-minute task is to explain her what MDT say, tell her what these treatments will involve, what will be the complications, tell her alternative options. So that 10-minute, just as a common sense, doesn't allow you to have to take the history. Now, if you will start taking the history, which again, when it says information gathering, don't always take information gathering means I need to take history. Information gathering means asking her anything. Is that okay with you? Will that plan be all right with you? No, I don't want to have this plan. Why? Is there any particular reasons? What are you concerned about? This is information gathering when you're asking this question. Because my friend had this blah, blah, blah and had this plan. And she's angry. She's not feeling happy. You told, okay, the other option can be surgery. But if we do this, you know that we have done that scenario already, yeah? So go back into gynae oncology module and re-listen it. So when she said that the further information gathering is to ask her, Linda, you appear to be quite upset to me. More than I can see, this obviously is very difficult situation. But is there anything else which is bothering you? You know, what's going on? How is your partner coping? This is the relevant information gathering in this particular scenario. So from this point onward, you don't need to take the history. If you will take the history, you will lose your time, and sometimes even the role player get angry.
Because
They do reflect
Satya,
as
this
well.
was the case. This was the scenario in my exam on same day, and it was the CA vulva and MDT report was there, and they suggested radiotherapy and chemo, and the second option was that's a surgery. So, but the thing is, the other details of her medical comorbidities, support, or if she is taking anything else other than the smoking, nothing was mentioned in the notes. Like it was a straightforward small scenario, and you have to go inside and just start explaining. So in that case, like, if I want to suggest an
so at this stage, all you're going to do is you actually going to tell her the plan, explain what to expect from here, explore her other concerns, because number one, you must keep in mind this team MDT, when they made this plan, they had all that information with them. All right, they have made this plan is considering all these anyway. So don't worry, you're not missing anything. But even if you are, you're not going to start any treatment straight away today anyway. Today, you are just giving her the information. So if she says, yes, I will go for radiotherapy, sorry, once you will arrange that radiotherapy, the radiotherapist will go through her notes again. No, that will be a radiotherapist's responsibility, even though he can assume if she has been set for this, she's fit for that, but still this is his prime responsibility to make sure this patient is suitable for the treatment he's going to initiate. So it's his headache now then again to ask about the history or check from the notes and go over to verify with the patient to make sure there's no contraindications for this history. For this radiotherapy treatment. So the initial
this is what I'm saying. Like, for example, if I want to suggest some lifestyle advices, or if I want to make sure that what social support she has, shall I offer her social support? Shall I talk about the services and everything? So shall I need these few things?
Right.
I mean,
so as I said, like, so the purpose of this scenario basically is what you need to do at this stage now to continue the care is to explain what the MDT has said, explain what these treatments will be like briefly, what can be the complications of these, then assess as well that this is stressful time, assess how she has been coping since we initially broke the bad news, how the family is coping, how the partner is coping. Do you feel it will be helpful if I arrange your counseling? You go again on your counseling, talk about the sport, talk about the Macmillan nurses. Okay, this is what is required. Now, Okay, so whenever you feel I need to take a history, always ask one question yourself. So this particular question I'm going to ask, what is that going to add to my management plan? So from all that today in 10 minutes you're supposed to do, to give the MDT plan and explain a brief idea about her sport and stuff. Other than that, if you ask about smoking, even if she's smoking now or not smoking, is that going to add or change any of the things from this scenario? No, right? So there's no purpose of going on those things. And then we know that the history and everything has been done is in your notes already, right? You're not going to initiate any treatment today or anything for which basically you need to make sure, do you have any allergies to any medicine? You're not going to basically give her any medicine now, right? You're not going to operate her straight away now, that you need to make sure her anesthesia fitness, does she have any diseases, does she have any problems, is she taking any medication, right? Yeah. So be very much clear. Information gathering does not necessarily mean you need to take a history, clinical history, right?
Because I saw the girls when
Okay.
they were practicing, they were saying, starting with like that, can you take me through the journey of briefly that what happened? And then they were starting.
That's
So 2,
the
3, 4
problem.
minutes,
That's the
3 minutes,
problem.
that is
I know.
was taking
I
long
know.
time.
I know.
Okay, thank
That's
you.
the problem for people, you know, all those mentors who are running these courses outside UK. No, keep things simple. You know, as I repeatedly said, this exam is very simple, very straightforward exam. Nothing is complicated here at all. Just stay natural. Keep it common sense. Okay, let's go to the next now. Right. Okay, so we have done the. So any other question? Anybody else has any question about MDT referrals?
Yes, Dr. Sophia, please. I'm not
Yes,
understanding.
Dr. Sophia, please. Hello?
Hello,
Hello.
Hello?
Yes.
Dr.
Yes.
Sophia. As regards this MDT referral, I'm referring for whom? For MDT team, or because MDT plan already done. You know, I'm not imagining whom I'm referring.
So in this case, I didn't quite get your question. Sorry. Repeat again. We
Dr.
started
Sophia,
from here.
Yeah, I understand, Dr. Sophia. I want to ask also the same question. In this
What is
form,
that?
there is A part and B part. The B part is the plan by the MDT itself. So they will respond to us in a fax or what? The B part.
All right. Okay. So your this form initially, when you complete, it will go on these details to this team, right? Email address here, fax number, and your telephone number. Okay. When the MDT this form, they will complete they will talk about, then either you or your consultant, one of your clinical team members will be in that meeting to write down the plan here. Okay. And then immediately after that, you will add these into the patient's notes as well. Okay, so that is there. So MDT itself won't be sending you, because you are part of the MDT. You are there. So nobody else is, none of these people need to actually send you anything. You have the form with you, or your consultant have the form with. And if nobody, your medical secretary is there then to write down what they say. But it's not, one of the clinical people will be there. Either yourself or your consultant will be part of this MDT, right? And you will bring it back. But they can fax back to your secretary as well, or to the consultant direct, if none of them is present over there. But that's unlikely, because unless you are there, yes, the information is there, but then if they need an additional information, if you are there for your patient, you can give that information quickly to them and look through the notes, you know where that information is. If none of them is there, and these are like general, and these consultants are not directly involved in the care of this patient, they will have to go through the long notes to find that piece of information. So one of you is always and must present in that meeting.
So, Dr. Sophia, if in teaching session and I am teaching the trainee about the referral form, I will tell part B. Then I will tell him about part B. It will be after the decision of MDT team.
Yeah. So from here, MDT outcome, then you will say, just like I have explained you, I have exactly taught you, basically, this is what exactly you need to teach to your student, okay, in your training. Explaining what is the importance of these part, what is the importance of this piece of information, why this is needed, exactly the way I have spoken. Obviously, I have gone too much detail. You can brief it slightly to accommodate in 10 minutes, but this is how you need to tell what needs to be done and the significance why. And yes, this part will be done, completed by the in the MDT meeting. So you won't be completing anything here. And then you will say, you will ask to
Dr. Sophia, also I have another.
Yeah. Go on.
Yeah, this target date within 2 weeks. This is from first seen patient by GP or from the diagnosis of her cancer.
Okay, so because we are referring it, it is from the histology report. Our 2 week target time will start our histology report when we establish the diagnosis.
Yes.
Okay.
And
But Dr. Sophia,
there is MDT meeting date. They are the MDT
Okay.
meeting date. They are making meeting in a special date every week or whatever the need.
No. There are fixed days and sessions. So say, for example, we do our MDT every Thursday afternoon. We do have our risk management meeting every Wednesday lunchtime. So there are fixed days and sessions, so the things are not delayed. Everybody will be there and the cases will be there as well.
Dr. Sophia, if I'm sending her to oncology center, then I should not attend the MDT. Suppose I'm sending to another center. So still I'll be there, or the referral letter will be different.
Okay, so that will then depend as well what you're doing. If it's an MDT referral, whether it's not inside your hospital, it's another hospital. If it's MDT referral, then yes, you need to be there. If it's a simple referral, that now this patient has been diagnosed and she needs this treatment, and you don't have actually the gynecologist in your unit, and for that you need to send now to another hospital to start the treatment, then you will just do the routine referral letter. But you will include that all information by saying the MDT decision was this, these findings are that, all this information will be there anyway, the first one. And you will write on the MDT plan as well, and then you will say thank you very much for accepting this patient to initiate the appropriate treatment management plan for her. But that usually is not the case. Yeah.
So that one is not MDT. That one is not an MDT referral. It is just a simple referral letter to oncology center.
Yeah. Yes.
Okay.
What do you mean by oncology center? Like the MDT meeting has happened, the treatment has been decided, and now you want to send to receive the treatment? If that's what you mean?
No, for example, I'm suspecting ovarian cancer. I am not oncologist. I need to send her to cancer center.
Right. Okay. Now, here in this country, we don't call it as a cancer centers. So every unit and every department will have their own oncology specialists. So for us, we'll be gynae oncologists. So they're part of your team. So every center will have their own gynae oncologist. And you will have your radiotherapist as well. So if that patient is seen by us and we have seen it is our patient, it will be treated locally with us. Unless there is some very complex kind of radiotherapy under very specific needs we need to do, then we will send it to specialist center, which will be tertiary care hospital. But she will be treated by gynae oncologists, not by the general oncologist. So there is no as such named as just the cancer center now. Okay.
You mean, Doctor,
Dr.
every
Sophia?
hospital has cancers? Every hospital can treat cancer?
Every hospital can treat cancer, and every team do have their own oncology specialists. So like bowel cancer surgeons, our routine, bowel team or gastroenterology team, they will have their bowel cancer surgeons, bowel cancer, urology will have their also oncologists, uro oncologists. We will have gynae oncologists, they will be called. So yes, every hospital have their own, these treatment and options and everything available, yes. CT scans,
And
everything
doctor,
can be done in it. Yeah.
where is this MDT? It will be.
It's in our hospital, in our department.
And
right?
we are referring by letter?
No, by this form.
By this form?
MDT. Yeah.
Yeah. And the MDT is in our trust, same trust.
Yes, it is.
Okay.
So what basically happened, to simplify more this procedure for you, when this patient comes in with vulval, all this picture, she basically, right from the beginning, she basically will be seen by the gynae oncologist. Okay. So the referral comes in. So what happens when the GP send the patients to the hospital? We just have a generalized that is called appointment center, right? They will put all the gynae related patients on one side, and then the gynae, the people they know is fast track referral. They will be sent to the gynae oncologist. If it's a postmenopausal bleeding, that will be sent to the postmenopausal bleeding clinician. They do have the names for them, and then they will come to my secretary. Say for example, I'm a gynae oncologist. I'm not, by the way. If it comes to me, then that appointment center will send all these type of referrals to my secretary, and my secretary will then in the morning show to me, right? And then according to priority, I will just say, okay, send these patient appointment in Monday clinic, these one Tuesday, and this. So then we will decide. So basically, these patients start, they get seen right from the beginning by the gynae oncologist. They will be taking the biopsy, right? So general gynecologist, I mean, there is no general gynecologist now anymore in this country anyway. Everybody is with their specialty. There is no general obstetrician or general gynae people here. No. They are either fetal medicine consultants, they are either fetal maternal medicine consultant, they are urogynecologists, they're gynae oncologist, or they are labor ward consultant, like this. So nobody is basically, there is no concept of general gynae or general thing. No, they are, every consultant is some sort of subspecialty consultant. Does that help?
Yes, thank you, Dr.
Yeah.
In case for your examination point, if you just for your knowledge purposes, so this patient comes in any gynae clinic, it won't happen though. As I said, from the letter, when it says fast track or suspicious, it will go to that team anyway. But in case it ends up to us, somebody different, then you will send them by saying, then before you take the biopsy, you will refer, you will immediately then make this patient's appointment with the gynae oncologist. Even for the biopsy, you won't be doing that biopsy. Okay. Okay.
Dr. Safiya, in the exam, they will give us the letter, or we have to know every single word in this letter?
Yeah. So no, I don't know. The people who have done this scenario in the exam, if somebody has faced this in the past, they can tell us whether they were the forms available, pro formas or not. But even if not, I will say that you actually make your own concept of these, that you must include all these steps. So you should know these by heart. So in that case, don't forget to, as I said, to this performer, after comorbidities, write down investigations, histology, and radiology. Delete this performance status, key family history. And you must, just like as we have a pattern of history taking in clinical examinations, make a pattern of this as well. So you know exactly to tell to that this needs to be added. Okay.
Okay. Thank you.
Okay. Right then. So we're gonna go to what is next now.
Dr. Safiya.
Yeah.
Yeah, please. If we apply that in that station, patient in front of me, means I will explain to her the result of MDT meeting. Then I will complete the form. This will be the theme of the station, or what?
Sorry, if you got the patient.
Yeah, that's the same station. The previous slide, I don't know. Means the patient in front of me, and I have the MDT result. Then I will explain to her.
Yeah.
Then I will the form in front of her.
Yes, so you will discuss MDT. So as I said, like, in urogyne module, we have done the
Yeah,
vulval cancer, same patient. So listen that recording, how you will open up.
Okay.
Okay. Okay. But that one, you won't straight away start, So when you are going to speak to, actually, I did have that slide after this. I just removed it today because I thought we have done it. I used to do actually next to it, that particular scenario. So for that one, then what will happen when you see the patient? As we said, don't just straight away start talking to say, our MDT has decided this. No, what did we say when we, so always imagine that continuity of care. So the first time, in the very first appointment, we saw her to break the bad news. We told her you'll get the cancer, and I'm afraid you got this and worried, and now we're going to discuss this in our MTT to see what is the best management plan for you. Then we concluded the station by saying, okay, so I'm going to arrange counseling for you. I'm going to make another appointment to see you in 2 weeks time, as soon as I have the that information from MTT to discuss with you what is the best management plan for you. Then we said, so meanwhile, if you have any questions, please do come back to us earlier or give the secretary a ring and she will make an appointment. Otherwise, on your next appointment, we will discuss all the questions if you had. Following that, this is what has happened. We said to that MDT meeting, blah, blah. We have done the MDT meeting and now we are continuing with her from this one. So how are we going to start the consultation with this patient? We need to start from where we left her. So first of all, after introduction, I'm going to ask her, so how have you been dealing? How have you been, or how have you been emotionally dealing with this hard and difficult news since last week, since we saw you first time, right? How are you coping with this? How is your family coping? Yeah, we did tell her it is stressful, it's going to be stressful, you all need counseling and blah, blah. So it's just natural to establish now how they have been coping in these 2 weeks. How is your partner coping with this, right? And did you have any questions before I, discuss with you what is the management plan for you? So just give that opportunity to her. Is there any other concerns you want to talk to me and discuss with me? And then you open up and say, okay, so as you know, in the last meeting, we said we're going to discuss that in our team of specialists called MDT to discuss what can be better management option for you. We have done that discussion now. And the team of doctors and those specialists feel that the best treatment for you will be to treat your cancer with the radiation. We call it radiotherapy. And what happens in that radiation, then make the vulva picture and say, you will be given that radiation. Then briefly just tell, that will be given in this targeted area, and that radiation which actually kills the cancer cells. And because although the measures will be taken to prevent it to go to the normal tissue, but still it can affect the normal tissue. So these complications can happen. So just listen to that scenario again, right? But the beginning, you must establish like that first, and then take her along. Okay, let's go to the next now. Right. Maternity dashboard. So maternity dashboard is also something which has come in the past exams. They want you to tell them what is maternity dashboard, why it is important, how that is used, who maintains the maternity dashboard, who review the maternity dashboard, and who is responsible to maintain the maternity dashboard. The maternity dashboard is a very simple thing. Dashboard means all of you have, some dashboards in your units, right? Where there is all the important information written. Yeah. So any note says this meeting will be on this date. For the team, the message is over the maternity dashboard. Yeah. Or whatever the dashboard in your staff room and your sitting rooms are. Yeah, something there to say this meeting will be on this date, or this thing is there, or this thing is there. So maternity dashboard basically simply means some notification board, you can say in simple words. Dashboard means, right? Now, why we need to maintain the maternity dashboard? So this is how the maternity dashboard looks like. Okay. This is online. The person now, which is usually asks you, who is responsible basically to make these entries and to make sure what is happening. So there is a named lead person for maternity dashboard, and that person is usually the clinical lead of that department as well, right? See, for example, if I'm the clinical governance lead of my department, this is actually my job. I have to keep an eye on that as well, in addition to my clinical duties, right? So, and what we do in this one, and what maternity dashboard is. So this is, as I said, it's a kind of a notification kind of, where you put some brief information, but comprehensive in a way that you can actually identify, again, what we are doing good according to the national set targets and standards, where we are just at the margin, and where we have actually failed the national target. Okay, so if you look at, and this is exactly, this is how it looks on our online system, these colors, and we don't do the colors. When I write 2, if that's within the range, it will automatically be green. If this number of deliveries shouldn't be more than 450, as soon as I write on 451 for that particular month, it will automatically go red. So what is the benefit of that? The benefit is when I see just on the visual look, I will quickly look what is this red and why that is red, what is happening in this red. Okay, what was this birth? So for our particular center, according to our staff and the resources and the beds available, it's like we should not have more than 450 deliveries in our unit per month. Yeah, because of the number of staff, because of the number of resources available. Yeah. So this is for a unit whose annual number of deliveries is about 5,000. So it's a kind of a big center, kind of, tertiary care center, you can say, or the secondary, like second proper hospital. Yeah. Per month, then, the deliveries in that particular unit, according to our staff and everything, shouldn't be more than 450. And the reason for that is why they need to say that to us is fine if we deliver more people. If we have more people and we have, say, on one night, we have 6 midwives, you remember your labor ward board, and you have 1 ST2 and 1 ST5 on duty and 1 consultant, you need to then limit the number of patients which you are seeing as well. You can't just keep it free, as many keep coming. Where are you going to make them to lie down? Who is going to examine that? And if you get more than what is manageable, then you are going to seriously compromise the safety of those patients. You simply will not have enough time to see all of them appropriately. Somebody may run 3-4 emergencies at the same time then. How are you going to manage it? Right? So that will seriously compromise the safety of that unit. So for that reason, when I see okay, if it's the only one of time, still I need to do some audit or something to find out why that happened, why we have so many more deliveries, what's happening actually. If our number of patients are increased, then I need to communicate with the local commissioners immediately to find out what we can do. And then why actually our unit was not closed before this, and why they didn't tell the patients actually to go to the neighboring unit, why they didn't talk to the neighboring unit to say, we are full to our capacity, so we will be directing our patient to your unit. Do you have a capacity over there? Right? So that's why it is important. If they are amber, that will also help me to quickly see what is going on. That means we're still within the recommended range, but we are, coming very close to where there. So I need to keep an eye to find out what's going on and what we can actually do to improve things. So there's what it is. So on this one, you can see there are 3 different colors. The goal means the national standard. So it is defined again by, say, the RCOG, or by, actually there are not particularly RCOG. We do have then, clinical commissioning and these monitoring groups as well, who will then decide what is the safety. So say, for example, you all might have read when you read this cesarean section guideline that every unit cesarean section rate should be less than 25. Okay. That means 20 less than 25, 25 is that magic number, is the national target. We should not go above 25% cesarean section per birth in 1 month. And if we are doing, then we seriously need to run an audit and find out what is happening. Why our cesarean section rate is so high? Are we failing basically to do the instrumental deliveries where they can be done? And why we're failing then? Why our instrumental deliveries are not as successful? Have they been actually the ST5s or whoever is on duty? Are they actually trying that? Are they doing the trial of instrumental, or they find it more easier just to go straight for the cesarean section? What's going on? Okay. So is a consultant involved in the decision? What happened? Why this rate is not? So then you will say there is one which says the goal, and then one is red flag. So the goal is nationally, it says your cesarean section rate should stay below 23% ideally. All right. But then they say they give it a margin as well, right? So 25. So 23 is the ideal. You're meeting the target. So as long as your cesarean section rate for that particular month is below 23%, when you add that here, say 19.321, it will stay green. The maximum level where the controlling standards of the bodies say you should not go beyond 25%, that is red. between 23 to 25, which is obviously 23 plus 0.1, 0.2, these 24, if we are in that range between our standard level and between our unacceptable, you can say, level, that will all go in amber. So the amber look will actually give me quick, just on my visual catch up, if I don't have enough time basically to just see everything carefully. At least these numbers will make me to look clearly immediately for that. But what are these, and this is amber, okay? I just go and review all these lesion sections for that month then to see what exactly is happening. Can I actually pick up some pattern? Yeah, right? So first month we went at 25 or 23. We have talked about 25 and 23.3, and it's amber. I will actually get the files of all those patients who have the lesion section done in that month, and I will review then what was the indication, was it there for some fetal distress, what was the CTG likes, was the fetal blood sampling done, what was the fetal blood sampling results, what was happening, could there be instrumental delivery done and this cesarean could be prevented? Did the registrar try for that? What happened? What was happening? So that helps you actually do that analysis. And when you find out something, that there is, say, you find out one particular registrar in her call, she has done the most cesarean. Like she does most, she doesn't actually try most of instrumental delivery. Then I may talk to her, check with her then what's going on. Maybe she's not confident to try those instrumental deliveries. And then she worries about, and she just gave up one go and doesn't go really good go for this instrumental, and she goes to cesarean section. Maybe that person is not very competent to do the fetal blood sampling. And when she sees the pathological CTG and stuff, she just try to take that lady for cesarean section, right? So these are the things that you try to find out what is, and if then you can prevent that from happening, right? So if I find particularly there is some training issues with that particular registrar, we might give her some more training sessions. We may, for the time being, take her off from independent, night on calls or day on calls, night on calls maybe. Daytime the consultant are there. She can just immediately call the consultant. And even if we might keep her on calls in the night as well. But ask her actually, before you take any cesarean in an instrumental delivery, call your consultant to come down as well for the instrumental delivery trial. So that will help her to improve her skills, as well as if she can't do it, then the consultant will do, and that will save this lady from harming the cesarean section. Okay, so that's the reason. So the maternity dashboard, the purpose of maternity dashboard is just a second. Yeah. So maternity dashboard help us to identify patient safety issues in advance so that timely and appropriate action can be taken to ensure a woman-centered, high-quality and safe maternity care, right? It can also be used as a benchmark activity and monitor the performance against the standards agreed locally for the maternity unit. So this one actually helps you to compare your results with your surrounding units as well, under your similar type of, who have the similar cohort of patients, to see how you are, and if everybody in your area, say Yorkshire area or, the London area or whatever that area is, if all these units in that area actually are struggling with these, the staffing level or these increased number of ratio, then that means there is some more wider problem with that particular cohort of the patient. What is happening then is that patients actually not accepting. They might be coming from particular mindset, particular community, who don't want to risk the instrumental deliveries. And those women are actually refusing to go for the trial. When you tell them about, there could be scarring, there could be a bruise in babies, right? They say, no, thank you very much, just do my cesarean section, right? So there are two purposes then. The first, individually you can identify quickly, and beforehand, before you start breaching and go into unsafe practice, that gives you an opportunity to pick up your things beforehand and do the measures to prevent falling into unsafe practice, these red ones. And the second is, then there are regional meetings where you all share your data, compare and see what is overall pattern going on in all that area, to find out maybe something more broader which can be fixed up. Yeah, you might then arrange some education awareness sessions for that community, and things like that. So something can be done then. So the maternity dashboard is to identify any safety related issues and any issues which actually prevent us from meeting the national targets. We can identify them timely, and we can actually fix them. So early identification of deviation from agreed goal and initiating a timely and appropriate action to be taken to avoid patient safety incidents and improve clinical care. So that's what the purpose is. When they say why we need the maternity dashboard, what is maternity dashboard, right? So in simple words, it's help us actually to identify the problems or any issues in the delivery of safe and high quality care to the patients. And it gives us opportunity to take appropriate actions in a timely manner to prevent any safety incident from happening. Now, we did use some words of set goals and standards. What are they? So I've just tried to explain it here simply. So set goals, local goals means now, obviously, you know, when I start like, so the nationally, they say the serious section rate shouldn't go more than 23%, 25% per total births. That means, where did they get that information? Yeah, from different audits, by observing, collecting the data from all the hospitals, maybe national wise. And then they found that the most average units actually are, you know, their maternity, their C-section rate is actually below 23%. Then they took it as the average by thinking, okay, so that is actually achievable. You know, the average rate was that. So then they set that standard that ideally should stay 23 and more than 25% is unacceptable, right? So this is how the national standards are fixed. And then we all as a services basically are sent the list of these targets, okay? All of these targets, like say, C-section rate should be ventos and forceps, 10 to 15% of our deliveries should be by instrumental delivery. If we are performing less than 5% or more than 20% of instrumental deliveries, that is a breach as well, and we need to investigate, right? Now, why are we saying less than 5%? Because less than 5% means we know the overall nature of the birth process. There will be some delayed labor second stages. So if we are even performing less than 5%, that is a matter of concern as well then, because that can either result that we are not applying, we are taking these patients directly for cesarean section, or we're actually delaying them and we're compromising actually our fetal outcomes. So I need to look at the APGAR score of that month's babies as well, then what's happening. If it goes more than 20%, then what is happening? Are there the midwives and the registrar, they're getting actually panic, and in the second stage, you know, patient is just deliver that patient quickly, do this ventos or clat and deliver this baby. Or what is happening? Are they not doing, you know, why? You know, what is the apprehension? Why is going more than that where it should be? Because obviously instrumental deliveries do have a morbidity. Yeah, we do know, even they are simple outlet forceps or vacuum, they still have the morbidity. So that's why, yeah, there is a range given for that. And then same, you can see different like stuffing level even. Yeah, if you see the stuffing level, what is the midwife to birth ratio? So they say 1.30, like there should be 1.3 patient for one midwife on the unit, right? So, and it should be more than 1.40, all right? Because that will compromise then the care. The midwife is then, so 1.30 means she basically may be seeing two patients. So one patient is for her completely to see her, you know, she will be saying. Then there's a one comparatively low risk patient, and she wanted to have a delivery in the, you know, in the obstetric unit instead of midwife or lead unit or at home, but she's a low risk pregnancy, right? So this lady may be seen by two midwives. So so those two midwives have one each of their own patients who need a more monitoring, but not quite 100% one-to-one, right? So in between, between both of themselves, they can manage the third patient as well, for example, right? Something like that. Or maybe this patient actually coordinator midwife will be saying, but when the coordinator midwife becomes some other reason, you know, when they call for help or will ask the coordinator midwife to do this, then the coordinator midwife can actually tell these other two midwives to see this patient as well between their patient. Okay, this is what this actually means. But if that goes more than 1.40, that means the number of staff in that unit is less. We have less midwives as compared to the number of patients we are admitting for labor, and that is not safe either. That's going to compromise. And that usually stays number. You know, maternity services is really deficient at the moment of staff, the doctors as well as the midwives. But anyway, But as long as we do identify that, every month we do the analysis, we do the recommendations, and then we keep writing it to our managers and to the team by saying we short of stuff, and then we are advertising, we're trying to recruit the midwives as long as we're doing their jobs. That are things we need to do, and we stay below red, then it's okay. But what is not acceptable, that is we are staying continuously number, but we're not doing anything. Well, it's still okay because we haven't touched the red. No. And if we started then going red, even from staffing point of view, and we went red for 1 or 2 months, then the center clinical quality control department or the team might ask us to actually to reduce the number of patients we are taking. So they might say, well, for your particular now, because the ratio of patients is calculated by according to number of staff, so for you, the unacceptable rate of birth is not 450, it will be 350. So you must keep your birth rates or the admissions below this certain number. And if you get more patients, then you need to negotiate with your neighboring units and then redirect your patients to them. Okay, so that's why it is important. Single red will then initiate, this will make me actually to run the audit. So cesarean section rate for say January 25.5, I will not only review all those cesareans to see what is going on, but I will actually ask one of my trainees to do audit on the cesarean section as well, management of cesarean section or management of labor or whatever the factors I find out, instrumental deliveries, they were not happening or whatever. So this is all, in the, now you remember when we did the audit in the beginning, we said the very first one, identify the problem or choose your topic. We said you may actually choose there from your maternity dashboard. This is maternity dashboard, right? So when I see this red, I'm immediately call one of the trainees and allocate this audit to that trainee to run that audit in detail to see what exactly is happening so that we can immediately do something about it. All right, and then depending upon the intensity and the importance of that particular benchmark, I'm also going to give her the time. So I might not actually ask her, actually, you complete that in 3 months. No, I might just say, instead of 1, 2 trainees together and take one midwife, I allocate, I name midwife, I've asked the midwife team to volunteer one of them to do that. And I make 3 or 4 people basically and ask them, okay, you're going to audit all cesarean sections done in last 2 months or last 3 months. We want to see the pattern, what's going on. Okay, so that's why the maternity dashboard is another source from where you identify the problem that we need to run an audit. Is this clear? Yeah.
Hello, ma'am.
Yeah.
Yes, ma'am. After we read the maternity dashboard and we found out what is the most problematic issues, then what next, ma'am? What should we do? Call for meeting or?
Yeah, we're coming to that now. Okay, so we did talk about the green, amber, and reds, what these means, yeah, and what actions we need to take after that. Then what happens? What parameters should be included? What things we actually monitor on a maternity dashboard? Clinical activity, just like SSR, like shoulder dystocia rate, serious section rate, instrumental delivery, workforce, which we had just talked about, the the staff patient ratio. Clinical outcomes like so shoulder dystocia, we know all the injuries are not preventable in shoulder dystocia, but then you need to put some minimum level, define those as well, like brachial plexus injuries if they are more than, say, for example, I don't exactly remember the number now, it should be here as well. So yeah, so let's say shoulder dystocia less than 6 per month is acceptable, but more than 10 months is they're not. So that's the clinical outcome. Messy PPH less than 10 per month is okay, more than 12 months is absolutely unacceptable. So that's about which things we do monitor here. Risk incidents and complaints of the patient from satisfaction. So all those risk incidences we are reporting, like shoulder dystocia and all that, so they need to be entered here as well. So some information we actually add here from the incidence reporting. So shoulder dystocia, these was risk managements. So how many number of instrumental deliveries and messy PPH shoulder dystocia, how I'm going to know that, from where I'm going to actually get that information, from his risk incidence form, right? So I will be entering that information from there. So this is how you get the information and put on. Now, who actually is the responsible? Who is responsible for maternity dashboard to complete that, make sure it's happening, and then actions are taken? So the lead consultant for the labor ward, which usually is the clinical governance lead as well. Someone with a clinical risk perspective. So this is somebody, it can be a member from your audit team. It can be a member from your risk management team. So somebody who understands, like us, just as I've explained, like what is the risk and all this, why that is important and what we need to do about it, and who understand this process, right? So it can be your coordinator midwife, it can be some manager. So we do have identified risk manager as well. The one is, again, the clinical governance consultant usually take the lead on all these issues. And then you have, as I said, like in the gynae team, other than consultant and the midwife, you will have one audit team as well. Similarly, you will have some manager like risk manager as well. That person who, if we need to, involve and take actions, that person will be, taking the responsibility. And this person doesn't need to be a clinical clinician, right? So lead midwife is also the part of this, and usually 1 or 2 trainees, because again, for 2 reasons. Number one, we need to involve them to do these audits and stuff, and also to understand that there's a part of the training as well. So on a rotatory basis, we usually have 1 or 2 trainees usually as a part of that team as well. And then this information every month should also be regularly passed on to the directorate management team. So this is then overall the trust management team for these type of incidences and these things, right? So every department is maintaining something like this in their own department, right? And then overall, then as the umbrella on the top of the trust itself has a, then on the top one team as well. We all need to send out this data to that team so they can keep it as a data of the trust. Okay, this is how it goes. And then we tell them, send them our plans as well. And in case we need any more funding, more staff, recruitment, then this trust, team, which we said, we will be sending to this. Where is that gone? Yeah, directorate management team. Okay, so this is the team which will have the finance people and everybody. So we'll be talking to them, as we said, the midwife staffing levels. So these are the people. Then I will be sending our business plan, and I will talking to them to say, but this is one, and this is we are, reaching to the breach of safety. So we immediately need new staff. So then they will advertise, they will create the funding to give, for that new member of the staff, and all the stuff, these arrangements and everything then will be made up by these people for us. And they will advertise the job and they will recruit the person. And then we will have that on our part of the team. Does that complete the loop now? From beginning up to the end, now what is maternity dashboard, why that is required, what we do when we identify something, and what further process take place, who are the people who maintain this, where that information that goes, where needs to be shared to take the actions. Some can be dealt locally within the team, just like as a silent, these things like this, should dissociate, that is high. We don't need any finance or anything from up there. Still, this all report will go to the directorate of the trust. But basically, all that need is for us to review, do some audit, and find out if there are any training deficiencies, which we will identify in the audit, those recommendations and implementations. And then we'll apply those, and we will be able to sort it out within the unit. But then we need to send that plan on the top as well. Because then what happens, the trust overall also need to keep an eye on their performance, how they are performing. Then the trust do have their regional data comparison as well. Then the trust overall as the performance are also compared with the national data. And then, there is something I'm talking about, CQC, clinical commissioning, clinical quality commissioning control. They come as overall to do the full inspection of the trust to make sure all the departments within the trust and within the departments, each different these things we are doing within the national standards and within the limits of high quality and safety. It's very accountable and strictly to the scrutiny system here in this country. From that point of view, a lot exhaustive work this month, and that makes working extremely stressful in this country as well. Because breach of anything can take you to any legal, patients complaints, sue, courts, you breaching this, getting penalty, hospital have to pay. Then you, as a responsible person, you are the person, you're not meeting the targets, it's just complex. Right. Any questions before we go to take a little break now? I'm absolutely exhausted now after talking for 2 hours, 3 hours, 4 hours now. Right. Good questions about maternity dashboard. Very good. Everybody seemed to understand fairly well. Okay.
What are the set of the question, the structure Viva here, doctor? I supposed to have, it's supposed to be 4 questions. For example, in this. Okay, now we understand it. So what will be the question usually in this?
The structured discussion about maternity dashboard has been, they have asked about, they've shown the maternity dashboard to girls, and they asked like, what is, just like I have added here, what is maternity dashboard? So they've asked like, what is maternity dashboard? So you need to tell this, help us to identify this. And then they have asked about, what these different entries mean, how these are entered, what is national targets, and what are these green numbers and these ranges mean, what is safe and this is unacceptable. And if this one has gone into red, what immediate action will be taken, what you are supposed to do then. So as I said, like, then I will review all those variant notes immediately. So the maternity dashboard lead person, who usually is clinical governance lead person, the consultant, did some training. They will review all this leading section of that month to see what exactly happened. And then they will plan an audit as well. An audit will be run to find out, why we're lagging behind, and then do the recommendations and implementations. That is actions you will take. And then there were the questions to ask whose is the responsibility for keeping and entering all this information into the maternity dashboard, which I've given over here. And then it was like the same thing as well. So if you have done, then where does this information goes from here then, so you have done, you have identified, you need to do something, which requires more, say you need to recruit the staff. So how is that going to happen? So then you need to say that you will share that, lead will share that information with the director of management, and you will then make a case to ask them to recruit new staff or make arrangements, whatever, new equipment, new theater, whatever you need. So that will be done. And then you will assess. So I'm aware of a couple of people have told me who faced this. I think that had been in 2017, some exams. So this is what the question was. So I have prepared these slides accordingly. Okay. Unless
Dr.
any of
Safia.
you know anything different.
Sophia, please. Dr. Sophia.
Yeah.
Hello. Please, can you send us the file for today? We need really this file.
Can we do what?
You post the file of the session, please, because all of us find it's very difficult on this topic.
Okay. All right.
Don't forget, please.
Okay.
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 Dr. Sophia, what is the redecorate management team?
Sorry, which?
Redecorate management team. This is in the last one who is responsible for the maternity dashboard.
Directory manager, not redecorate.
Directorate management.
Last.
Yeah.
Yeah, this is the one.
Okay, so directorate management is overall trust team. They are called directorate, means their department, and management means, I mean, this is how they are called. So they are the people who they are part of, you can say, not just the audit, the audit department, but they are like bigger structure of that department. So we will be sending our recommendations and all that information. So they will be maintaining all this data and this type of information for all these specialties, medicine, peds, surgery, everything. And then what needs to be done? These are the people, managers, who will then arrange if recruitment needs to be done. So they are a bit like higher level of management.
Okay, thank you.
Okay, so what we will do then, take a little break, and then instead of going through the consent and this type of complex stuff, we keep the consent for next time, and also the risk management. We can do 2 simple scenarios like reflection your trainee want to do the reflection and also bullying. Will that be okay?
Of course, it's okay. But the next session, it will be for teams marriage, not next week, yeah?
No, that will be 14th and 15th of March. That will be Saturday and Sunday, 14th and 15th of March.
At what time? Morning?
9:30, 9:30.
9:30 a.m. Yes, morning.
Yeah.
No, but next
Okay.
session will be next week, next Friday, right? The concept.
No, basically 15 Friday sessions we have completed now, but because I want all those things to be done as well, like structure discussions. So those we're gonna do Saturday and Sunday. That was teaching this clinical governance session for Saturday and Sunday batch, but Saturday and Sunday batch is also doing clinical governance today, right? So we can use those two sessions then to do some extra like structure discussions and the remaining things related to.
To Sophia, I have a request to Sophia, please.
Yeah.
As you know, all of us has a financial issue, so we'd like to make the one-to-one support instead of 28 session. You can make it as 14 session by half of price. It will be very affordable for all of us to join this.
Yeah, that's fine. That's fine. You can do
As
whatever the way you like. No
yes,
worries.
I think it's fine because if I'd like to join one-to-one support 28, it will be very expensive for me. But if you'd like, if you make it as 14 session, it will be very
It's fine.
affordable for most of us. What do you think?
It's fine. It's up
It's
to you
okay?
guys. Yes, you can do as a single circuit. You can do two. I will be doing one mock circuit at the end for all of you anyway. So there will be one mock proper circuit, but that will be obviously different. But yes, for one-to-one, it's quite flexible thing, and it's personal needs tailored according to personal needs. So of course you can discuss that with me later on after this session. If you want to
Okay,
do one, that's fine. 14 stations, you can take it. No
okay,
worries.
thank you so much, ma'am. It's okay. Thank you.
Absolutely fine. So let's have a 10 minutes break. And are we okay to then do two further? There will be more like scenarios then. They won't be that exhaustive and long.
Okay, thank you.
That's okay. Okay.
Right, hello. Okay, let's do something really interesting now. And lice as well. Okay, is everybody back? Hello? Yeah, okay. So who wants to do this scenario? Friday batch people?
Yes, doctor, I can try.
Okay. Right. So yeah. So just a routine as we do. So this is your first 2 minutes.
This is Viva?
Yeah, very structured discussion. Yeah.
Okay. Okay, doctor.
Okay. Yeah. You want to start?
Hello, I'm Samah, candidate for the exam. I read the scenario and I'm ready for the discussion.
Okay. Okay. So right. Just give me 1 second about this particular scenario. Then, do you want to do it as a structured discussion, or do you want to do it as a role player? You know. Anybody knows this type of scenario in the past in exam? How did it come? Like, was it a structured discussion or it was like a...
It was like colleague communication with colleague, but if structured discussion may be more hard, I don't know.
let's do it. I will cover both, but if it has come as a simulated scenario, then let's do it like that then. So I will be your ST1, your ST1, and my name is Barbara. Good. Okay. Yeah. Okay. So I'm going to be your ST1 Barbara Wood.
Okay. Okay. Hello, Barbara. This is Samah, the ST5. How are you doing?
Yes, hello, Dr. Sama. Yeah, but not great, really.
Can I ask you what is bothering you exactly?
So you imagine she's crying. I'm really upset, Dr. Sama. You know, since I have come to this unit, I'm really troubled by the midwives. I feel they, they they undermine me all the time, and so I don't feel their behavior is good towards me at all.
I'm really sorry you are feeling that these all feelings, and it must be tough for you. And is it affecting your work or your care of the patients?
Well, yes, it's been really, it's been really upsetting, and I dread coming on the labor ward when I have my duties in the labor ward. Well, I'm trying to work and focus on my work, but these two midwives, when they stay with me, they just, they just kind of, they try to embarrass me, and then, they call me to see the patient, and then they will just not agree what I'm saying, and I see they don't value whatever the opinion I give about the patient. So I don't know why then they ask me first place to come down and see their patient.
Actually, yeah, actually, it's not acceptable to treat our colleagues like this, Barbara. And you have to talk to them why they are dealing with you like this. Do you try to talk to them before?
No, I haven't, because I don't feel I can talk to them. They both are really senior midwives, and I don't think they will be willing to listen to me anyway, and I don't want to upset them, because they've been so senior and old midwives working here for such a long time. I don't want to put myself in trouble.
You know, Barbara, keeping your thoughts and your feeling inside your chest, it will make the matter more complicated, and it will make you prone and make the patient safety prone to have some issues. So better to relieve your chest, better to talk. If you don't wish to talk to them, you can to talk to one of your colleague and one you trust in, or even your educational supervisor. Have you tried anything of that before?
No, I haven't. I haven't talked to anybody before. It's the first time. I'm just telling you. I don't know exactly what to do, to be honest, because as I said, they both are senior midwives, and they must be very close to the consultants as well. So, I just don't want to, upset. And if I talk to my supervisor, I don't want to be perceived as if I have been complaining about them. So they might go, upset, and then I might be in even more trouble.
First of all, I'm very happy you are opening your chest for me and telling what's your feeling, and this is I'm encouraging you to do so, and I will do my best to help you in this issue. And second thing, um, 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 nobody have the right, even if they are senior, or even if they are close to the consultant, to deal with you like this. And don't worry, we are all in our beginning of our career, we can face some difficulties, but we have to solve it together. So I'm encouraging you to, first of all, to talk to them in private, not in front of the patient, and to maybe some small misunderstanding, and it will be resolved if you talk to them. If you don't wish, or you're afraid, or if you still you have the conflict with them, you can upgrade the condition to the senior midwife or your educational supervisor, and I think you will face support from all of us. How you feel about that?
I don't know. I'm really stressed at the moment. I don't know, to be honest, how to address it, because I'm really worried, that if I did that, and I'm been this unit only for last 3 months, so I still have to, spend here another 9 months at least. I don't want to really make people against me, and I'm the most junior person on the team, and I don't know what to do.
Have you ever been thought about changing your career or your specialty because of that issue?
Well, just recently, sometime I find, I don't want to change, but recently I have been so much, stressed out of this that I have been kind of, thinking about that I wish it was possible that I go change specialty and go to somewhere else, really.
I can see it's very stressful for you. Do you think to take some days off to sit with your family, think more clearly?
I had taken time, I have taken, some couple of days off already twice because of that, because whenever I have my rotation on labor ward, I'm so frightened. I really dread to come to labor ward. So I've already taken twice, 2 days each episode. So obviously I can't keep taking days off from work.
Yeah. Don't be frightened. I'm here with you, Barbara. I will help you. Let's go together and talk to your supervisor, or you can even write a written complaint, and we can upgrade it to what it's called workplace behavior champion. This is a separate organization. They know our trust and who is working and everyone. They can make investigation, and this will not affect you at all or your future.
Well, my supervisor
What do you
is
think?
Mr. Wilson, and one of these midwives, Linda. She's a really good working relationship with Mr. Wilson. I have seen her, and Mr. Wilson, he just is so close to these midwives. I don't think if I go and speak to him, I being the most junior person on the floor, he's actually going to blame me and go against these 2 senior midwives who've been in the unit for last about 15 years. I'm really frightened to talk to anybody about it.
So we can escalate to other person, maybe our medical director. How's that sound for you?
I don't know, would that be right? I mean, just going to medical director.
Hello?
That,
Yes, we can go together and explain to him. We can, like I told you, we can escalate even to the GMC if they find some problem. Any of other your colleague are in the same situation, Barbara? They are undermined by these midwives.
I haven't spoken to anybody.
Because if we are preventing them now, we will prevent them to treat your colleagues like this. So we have to take action.
Yeah, I think so. I also think same, yeah.
Yeah, and I will give you also my contact number and the contact number of our professional counselor. You can sit and talk to him, relieve your chest.
Yeah.
Okay, this is will help you a lot.
Yeah, okay. I think that would be helpful, yeah.
Yeah. So let's go together and talk to our medical director.
Okay. I think I'm not quite ready to go straight now. I will have a think about it, Dr. Summer.
Okay, let's okay.
Yeah.
So think and tell me. This is my contact number. At any time, I am more than happy to help you.
Okay, thank you, doctor. You've been really helpful. You've been really supportive, yeah. Thank you. Right, okay. Well then, you did handle quite nicely. Yeah, so there is some standard pathway. There is a standard policy to deal with bullying and harassment at work. And there are, again, a proper pathway, like there are like appropriate personnels who you can go and talk to about these things. So there are two things here. There are rather three things here we need to consider. Number one, first and immediate, which you did address, is to establish our immediate well-being, our emotional and psychological well-being. And that needs to be in two forms as well. One is immediate short-term and one is long-term. So the short-term is we need to actually assess her condition now if she's on delivery, so we're doing duty and she's so upset and tearful, and while those two midwives are on duty as well. So to first, get some detail, what exactly happened, what has happened, why she feels she's being getting undermined. We should give some idea, vague, but we could ask a little bit more. And then also to see whether she is actually now able to continue with the work. If some recent incident, just some incidents happen now, is she able to continue with the duty for the rest of the day, or we need to actually send her off? She may not be safe to continue to work. So that's a short-term well-being. The long-term well-being we need to also then establish to overall assess her and ask her questions of any long-term anxiety and depression symptoms. So you need to check whether how she's coping. Has she spoken to anybody at home? Has she got any support at home? Who is at home she can talk to? And does she have a partner? Has she spoken to the partner? What type of support she has from the partner? And then we need to do some proper assessment to say for depression, to ask her, has she been eating and drinking okay? How she feel like coming onto the work, and it's only when her duties on the delivery suite and labor ward she's worried and stressed, or she's stressed now throughout. You did ask about focus and concentration. Yes, that's very important to us. Has she been able to sleep okay? And if she says yes to certain things, then she appears to be struggling with stress and anxiety, then we need to encourage her to take some time off. We should did touch, but then you kind of just left it in the middle. So we need to do that. encourage her to assess one of the counseling sports and services, and there are different levels of those sports as well, which I will explain in a minute. And we can encourage her to see GPS actually from her other issues as well. We need to reassure her it's okay to take time off if she's, not feeling, because she said I have taken twice a couple of days off already. I can't really take now because of this. So we need to tell about a bit of policy about the, under work-related stress, what she can do. And then also to address them, there is a cascade, a process, how you can escalate it from one level to other, and what can be done. So the first one will be, as you introduce yourself, it was nice to ask about the colleague to say, hi, Barbara, I'm Dr. Sama. You're ST5 here. Then just establish, Bessie, I can see you're very upset and, you appear to be tearful. First, check with her whether she would like to discuss something with you. So then you can ask her basically first to say, would that be okay? If I can ask what is bothering you, what is making you so upset? Yeah? So,
Sophia, please mute Dr. Tahira.
I need to mute people, yeah. So first you need to establish with her to ask that, can I ask you, would you like to share with me why you're so upset? Is everything okay with you here at work? And then see what she says, yeah? And then if she comes up and say, if she doesn't open up straight away, you can say, it's okay if you don't feel quite ready to talk to me about what has happened. It's fine, you take your time. But I think it will be quite helpful if you can discuss with me or give me some idea what's going on, because I may be able to help you with the matter. So, let me know what can be of help. Then ask her if she opens up and say, well, this is what is happening, and those midwives are. In this scenario, you need to be like, listen her quite a lot. And first, encourage her to come up with ideas, how she wants to resolve it. So when she starts telling you, then you can listen and say, okay, can you, so how long this all been going? Can you give me a couple of examples of their some incidences when this happened, which make you to feel? Because sometimes it may not be, it's just her, the interpretation. So just ask her to give, tell me like a couple of examples, what exactly happened. And then after that, you can, next question you can ask, you can say, okay, so if it is inappropriate, then you can say, well, yeah, that's not right. And this is not, absolutely unacceptable. This shouldn't happen like that, because it can affect not only your emotional and physical health, but it can also make you more vulnerable. And you can be at a risk of making serious errors, which can compromise patient safety and the care. And for that reason, in all the NHS trusts, the colleagues harassment and bullying is absolutely unacceptable. And then you will ask her to say, right, okay, so have you spoken to them, any of them? Have you expressed to them, like, the way they talk to you, or the way they deal with you or treat you, that is quite upsetting you, and that actually is affecting your performance? So first check, have you spoken to them? Have you noticed them doing the same thing to be your other colleagues, of your ST1 and ST2 colleagues? Have you spoken to any one of those, your colleagues of your, training level? And then you can ask first, instead of straight away recommending that you must go and you must talk and you should do that, just ask how you feel about. So how you have, what you think. How would you like to resolve it? Because obviously it cannot be continued. It cannot be allowed to continue. So what you feel, have you given it a thought? Do you have any plans how it should be addressed? So if you have any idea already, that's fine. Otherwise, the way to deal with that is, first you will encourage her to say, I feel it would be a good idea if you feel you can talk to them, you talk to them. You can talk to them individually. Just go and tell them first, this is how you feel about their behavior, and that's quite upsetting you. Because what happens, sometimes the person
who apparently is bullying or doing the harassment, he or she herself is not actually aware that the way she speaks or her behavior actually is upsetting others. So, you know, maybe when you talk to them, they just recognize and acknowledge this, and that may help them to change their behavior, the way they approach, you know, the junior doctors or any other colleagues. And then you can ask her, so how you feel about that, going and talking to them. So if she then say, then it's a very typical scenario. These junior doctors, we see they feel, I know she's really, you know, they're quite old, quite senior midwives over here. I don't really feel I can go and talk to them and all that stuff. Then you can say, so how you feel about talking to the midwife coordinator. If she feels the same, then you can say, I can see, you know, that you are quite frightened. And you're quite anxious as well, that if you raise any concern, if you try to do something about it, then you may get, you know, victimized or more penalized. But that is not the case. So there is a very clear and supportive policy of the trust. So, you know, what you can't do then, if you don't want to talk to them, it's absolutely fine. You don't need to go and talk to them. The best thing for you to do then will be to speak to your supervisor, you know, let him know. And then she said, well, Mr. Wilson is my supervisor, and he's one of the senior consultants as well, and he's very nice and very good. They're both with him, and, you know, he's not going to, I don't think he's going to listen to me. He might feel I'm complaining. Then actually you need to reassure by saying, you're right, even if they are very senior team members, and Mr. Wilson has a very good working relationship with them, but then at the same time, it is Mr. Wilson's and all of us, you know, as your colleagues and your supervisor, it is actually our responsibility to ensure that none of our colleagues, and particularly our junior colleagues and the trainees, they're not actually, you know, bullied or harassed by anybody. So I don't think you need to worry at all about it, that Mr. Wilson may not listen to you, or he may not believe you, or he might go against you. That is absolutely not the case. It won't happen. So, because this is priority, it's a part of his, you know, duty being your supervisor to make sure that the working environment for you is quite comfortable. So this is you can encourage her to speak to the immediate supervisor. Then you can say, so other than that, I would say the other thing to do is you can speak to the clinical tutor. So the clinical tutor is the overall one consultant, which is given that duty of the clinical tutor. He's over responsible for the training of all of these trainees. So that is another, most of the trainees actually are very close to the clinical tutor consultant as well, because that person basically have all the interest to make sure he's given the main responsibility to ensure the trainees are getting appropriate training and under good conditions. So that's why the clinical tutor can be the next person. Then you can say, so, you know, there is a clear policy on that. So what I will do then after this, you know, a discussion with you, I can actually show you that link, and we can actually download and print that policy for you. You know, bullying and harassment policy, and you can read that. So at this stage, you can, you know, report this as the informal, you know, speak to you. So this is called informal, in which, you know, if you choose to speak to your supervisor, then he can speak to those midwives and try to understand their and convey the message that how you feel about the behavior, and he can encourage them to, you know, approach you in a more sensitive and more sensible manner. You know, then he can, you know, check with you as well. You can speak with, you know, any improvement in the behavior and the conditions for you. If you're feeling very much stressed at this stage, I will strongly encourage you to take some time off, so that you can have some time actually to stay away from work, to be able to think and concentrate and recover from this immediate stress. And if she says, I don't want to take that, and then ask how you feel about it, right? How you feel about it. If she says okay, then you can say, you know, there is a trust policy as well. This is called work-related stress, sickness leave due to work-related stress. And if she says no, I don't want to, and I maybe, you know, have already taken, just say, don't worry about that, because it's very important that if you're upset, you don't work, because it can put you make you quite vulnerable to make serious errors, which is not safe for the patients. And that's not good for you either. Okay, so encourage her to take some time off if she's really disturbed and upset. So then you can encourage her to, you know, access some counseling service, which she can do either through GP or you can then tell her to then contact BMA. BMA is British Medical Association. So you can say, so are you a member of BMA, British Medical Association? And even if she's not, if she says yes, then it's fine. If she says no, then still you can say, so I will give the contact details of British Medical Association. This is an organization who do support all the doctors and the trainees, and they do help actually to address these issues as well. If you are bullied or harassed at the workplace, so they can actually help you to, they can speak to, you know, the consultant supervisor or to the human resources, the, you know, the team who's responsible for bullying and harassment and trust. And they can present your case. And if they, you know, later on fix some meeting with you to talk to you, then they can come down and go with you in that meeting to explain on your behalf. So that is another thing. Then you can say, if she's absolutely says at this stage, I'm not ready to listen anything, you know, go, or I don't think at the moment I can do it, it's okay. You take your time, you take some time off, recover from these immediate symptoms of your stress, and once you start feeling a little better, then we can talk about this. But I would strongly encourage you to try to resolve this matter, because if it continued, then obviously that will be kind of an encouragement to the that bullying behavior of those midwives. And you know, who knows, they might be actually doing the same with your other colleagues as well, other junior doctors, and that cannot be allowed. Okay, so this needs to stop. But it's fine if you're not ready quite at this stage, we can leave it for the time being. So how you feel about if we meet after another week again to discuss, and meanwhile I give you the contact details of the British Medical Association, give them a ring. They can discuss all the things confidentially with you, and it's quite confidential. They can also provide you the counseling support that's called counseling from doctors to doctors. And you know, and that's really good as well, because being the doctors who provide that counseling to you, they themselves being in training, they're aware of all these issues, and they can really help you very good. And it's absolutely confidential. It won't be disclosed to your work or to your, you know, human resources. So yeah, so that's what we do. So you can encourage him to how to first talk to the midwife coordinator, if not to your supervisor, if not to the clinical tutor. And if not, we go, this doesn't go straight to medical director. Medical director is quite high up in the trust. So if she doesn't want to speak the people within the department, then the next is the human resources officer responsible for this. So for that one, you will need to say, then I will check on the transparency of harassment, who is the, which, you know, human resource officer is responsible for this. So we can contact her then if you feel like that. And then conclude by, if she's ready, then you can say, okay, I can give the support by saying as well, if you like, I can go with you to speak with you. But if not, then we encourage her to contact the BMA, take advice from them, how to, you know, address her issues. They can help. And then arrange another meeting with her for about another 1 to 2 weeks time to check on her to see how the things are going and what she would like to do. Okay. I have summarized this in one recording as well, so I will forward that recording to all of you in the group. Any questions?
Thank you, Dr. Safia, very much. For if it came like structure viva, what we will do? What's the question and what was the answer?
Okay, so if it comes as a structure viva, then it will be same thing. You will say the same thing, that, you know, you will start by saying that the bullying and harassment is absolutely unacceptable. Because obviously it does spoil the working environment, and it compromises the safety and the quality of the care we provide to our patients. So the all you know, the NHS organizations do have very strong anti-bullying and harassment policies, and it is, you know, absolutely intolerable. And then you will do the same way, that if I see any of these colleagues, then you can say it's the responsibility of the whole team, that if we see any of our colleagues getting victimized or bullied or harassed by any member of the staff, we either we speak to the person who is bullying them to, you know,
tell them about their unacceptable behavior and ask them to stop this. We can also, it's very important, we do talk to the affected person or the bullied person, the colleague as well, and check with them, and then you can talk about this all immediate well-being thing to check their emotional and physical well-being, because this bullying and harassment can obviously do quite a lot of stress and depression, and it can seriously affect their ability to work safely, and it can, take them into proper clinical depression. So it's very important that we do that assessment, talk to them, and then ensure that they do have some support at home, have they discussed with somebody, encourage them to support with their, talk to their partner or some family members for support, speak to the GP, check with them, have they been able to sleep and, eat and drink, and if not, then see the doctor, and if they need any, any medication for the time being, to do that, and also to arrange some counseling. Depending upon how much they are affected, it's very important we do check with them to again see, are you able to focus or concentrate on your work, and if their ability is compromised, then encourage them to take time off. Speak to, with the permission of that person, obviously, make a plan how this should be addressed, encourage that person to actually address and resolve the issue, and reassure them that you will not be victimized, you will rather be supported very well, because there's a trust policy and their supervisor and all of us as a colleague, we do have that basic and very important responsibility to make sure that we stop that bullying from happening. So we will provide the support and reassurance to that trainee. And then you will make the trainee aware of the process of resolving this, and how they can escalate this matter. And for that one, then the first step is obviously you will encourage that person to talk to the person who's bullying them directly. If they feel they cannot speak, you will encourage that person to speak to their supervisor, clinical tutor, and then you will also inform that person about the trust policy. You will download, print the policy for them, so that they can actually go through the process, how they can put the complaint on. So, and then in the complaint, you should know about, there are two basically stages to do that. The first one is called informal procedure. Informal procedure, when you simply just talk to your consultant supervisor or to them, and then that person will talk to the midwives, and they will try to resolve and put some plan in place, like tell those midwives what is acceptable behavior from them, and then also inform the trainee, and encourage the trainee as well to say the trainee doesn't feel any pressure, and then speak to the trainee after doing an assessment meeting after a few weeks to see if the things have changed. And if not, then the next stage will be called the formal procedure. In the second stage of the formal process, basically, then that trainee will put this complaint in written, and then in collaboration with like the consultant supervisor or the coordinator midwife from the other side, and also one member from HR, human resources, who is responsible for that particular aspect, that team will be formed, and in which they will then interview this trainee. And then they will interview those midwives. Then they might interview some other members of staff who may have witnessed these incidences from happening. Meanwhile, you will encourage the trainee actually to write down all the incidences, what happens with date and time, like what exactly happened, so that they can be used, as reference. And obviously, meanwhile, you will provide the counseling support, arrange the counseling support for the trainee as well. And then you need to tell that you will speak to the trainee to contact British Medical Association. So this organization, I mean, everybody knows the BMA here anyway, even from student time. So obviously that is the organization who support the doctors and help them. So they help basically to present the cases as well. They provide counseling. They come down actually to present the case and do all these negotiations. And then some resolution can be achieved. Okay, so this is obvious. So you say, the main thing is there is this champion, behavior champion or bullying champion type of things. Basically, that's not quite practically something which exists, because there is like proper process in place. There is a clear pathway. As I said, there is a policy, anti-bullying and harassment policy of the trust. And then there are proper steps to follow that. So it's not like somebody try to find out who can help. Like, they are very clearly defined people. These are the people you can go this, do this, and do this will be the steps. The people know exactly.
and the process should be very simple and easy as well for the victims to follow. Yeah. Okay. Any questions?
Yes, doctor. In the scenario, they told that it's coming as a colleague wants to know about some strange data like odd ratio or Cochrane study. So how to in a simple way to يعني get out from this we are not know this odd ratio and Cochrane.
So when a scenario comes like that, where yes, so there has been some scenario where basically you are from the scenario, it appears like you're going to do some teaching session to explain something, but then during the process you find out that's not the case. So what happens in that scenario is but keep yourself neutral first to start with. Don't just by seeing that particular scenario think, oh, I know it actually is about bullying and harassment, because that's what we know from recalls. No, keep your mind open. So how you can actually identify they put their scenario actually first to put like, are you able to identify that your colleagues may be the subject of bullying and these harassment and these behaviors? So what basically will happen if it comes as a teaching station, you go in, introduce yourself, just ask a few initial things first, just like a social. Then again, how long you've been in this unit now, and how the things going on, how is the staff behavior towards you, are you feeling comfortable, are you happy working over here with the team? Yeah, so just ask these direct questions. So most of the time they will actually open up, might be even there at that stage, give you some clue by saying, well, not really, it's difficult, or I've been struggling. So they might give you some clue straight away there. If not, then obviously, if they feel okay, or look at that, if they appear like any unusual behavior, they look tired or depressed or not making direct eye-to-eye contact, then you can still continue. Don't jump and insist on things, then you can continue by saying, if they're not making direct eye contact and they appear like upset or something, then you can straight away say, so I understand today's session you have booked for, for this tutorial, to discuss this and this. However, you appear to be quite upset and stressed to me. So would you like to discuss with me and share with me, is there anything, going on at work or at home, which is, affecting you, or you're concerned or worried about? So invite her at the beginning. If she doesn't open up and if she say no, and say if, then you go to the next step. So if you follow basically these steps, that you will pick up. There's no way that you're directly asking things, but don't kind of straight away keep saying as well, is anybody bullying you or anybody doing the harassment? Don't straight away say that unless the person opens up. If she still doesn't open up, and this should be routine thing, even for your routine teaching style as well, even if that scenario is really for teaching, so just keep it natural, as I said. So when you start talking and explaining something to it, then that person will give you, because what happens when somebody's really stressed and depressed for any reason, they won't be able to focus what you're teaching to them. So when you will ask, are you with me? Are they appear not, then you can say, even at that stage, you can then stop and say, don't again say, you're not focusing or concentrating. No, instead say, I can see you're quite upset and you're not able to quite focus what we are discussing. So put whatever you're trying to explain out on one side, say, okay, so before I actually do that, can I be of any help to you? Is there anything you would like to discuss with me? I may be able to help you. You appear quite upset to me and quite, disturbed. And then she will open up. If there is anything like that, she will open up. If not, then it's okay. Continue with your routine teaching, it's not necessary. But anyway, if she opens up, then this is exactly, then you're going to progress then. Would you like to tell me? So stay really patient, listen to her, encourage her maximum. So when she ask her, so can you give me some examples exactly what happened? And has anybody else witnessed you when this was happening and they were misbehaving to you? Are they doing the same with other, and all those things which you have discussed before? Yeah. Okay. Any questions? Quick questions before we go. Did you guys want to do one more on the reflection, or is this enough for today? I'm aware it's quite heavy session today, so
Sophia,
Doctor, should we say it will be confidential between you and me?
Yes, yes. So when you initially start and encourage, so you can say, yeah, you should say basically that, you know, it will stay confidential. So you can discuss and share with me.
Okay, thank you.
Yeah, the most important thing here is to encourage her. If she express any worries by saying they're very senior members of staff and I don't want them to get and upset people like that, then you need to say, don't worry about this at all. Because the trust has zero tolerance on that. It's extremely unacceptable. And your supervisor, you're all the consultants you're working with, and even us being your colleague, it is our prime responsibility that we make sure that none of our colleagues is actually being subjected to bullying and harassment. So basically, the whole team will be very supportive towards with you, and nobody actually, you're not going to get penalized or victimized because of this. I can certainly reassure you that. And there is a very clear and strong policy of the trust, which is called anti-bullying and harassment policy. And then encouraged to say, I can play that for you. Right. Any other question? Right. So what you want to do then, you guys? Do you want me to do the reflection scenario where the girl has missed the diagnosis? Or we can otherwise do it in next session, but if you want, if you're okay at the moment, I can do, I mean, it's 8 o'clock already, so 5 hours into session.
can you make it with the next session, please?
So that's Hala's opinion. What other people want? So the two people, not with very clear IDs, please, if you are logging in with a different ID, let me know beforehand. So caller 42, can you please tell me who you are? Somebody has logged in by caller ID of caller 42. And then somebody else says like some funny face written with A. This is weird. No response.
Sophia, you can excuse anyone unknown for you.
A1. Who is that A1?
No. Yeah, you can excuse. You can dismiss.
I know I
any.
can, but I just want to make sure, you know, sometime you might be, the people might be logging in, you know. Right, okay, so quickly do your voting. You want to continue or not? I know some people have given their opinion, but the other ones quickly put on so I can just see what majority of you wants to do. Right. Continue, and continue. Let be with next session. Huda wants it with the next session. Hala wants it with next session. Dipti, Samanaval, Samasundas, they all want to continue. Mary next, Rosea. It is 1:30. Okay, that's fine. I think you are tired. What I will be doing, I will send you the audio recording of reflection anyway, and then we'll be doing the next session as well. Don't worry, you know, if we have to do any further additional sessions and stuff, we will do then. I will cover all the important topics which needs to be done. I think most of you feel like much tired, and I can understand it's quite late in India and Pakistan. So, okay, so have a good night, take a good sleep. You will get this recording, and then on WhatsApp group, I will be sending you the audio recording of bullying and the reflection both as well for summary, so that you can just, so the main way to do this is please listen them again and again and again, just like instead of music these days now, you know, put these recordings when you're driving to work, when you're coming back from work, but one module at one time. Okay, so put one module, keep listening it for, you know, 2-3 days on your way to work, back to work, working, put that into your ear, repeatedly listening those scenario. What happens is your subconscious become actually used to that terminology, that time management and everything, and then you just keep doing that. Okay, but one module at one time. At least you have listened it 2-3 times, then move to the next one, because otherwise there is too much for the brain to retain. I strongly suggest you to listen on your ways to work and back from work. Make it a routine, and then try to, you know, if you listen when you're going to the work, then apply that on your patients. You know, you would have recently listened, this apply that on them, and that's the best way to practice it. Okay, so yes, so good night, good evening, according to your local times.
Hello, Doctor. What will be next session?
For overall Friday batch, rather for the whole group, the next session will be on 14th and 15th now, Saturday and Sunday. I know there are a few people who have just started today, so I will talk to them separately. So Rajana, I will speak to you about further sessions. Tomorrow will be labor ward management. So obviously that group still has to do labor ward management and delivery management. So we will be doing that tomorrow. So tomorrow's session,
it will be different scenario than Friday batch, or the same?
Right. So because there are two groups. So the first group on Saturday, the first 7 scenarios will be same as the Friday batch has done already. On Sunday, those scenarios will be different. After 7, so, the remaining will be different.
After what?
The first 7 scenarios on Saturday will be same. Sunday will be different.
So from next Sunday, the station will be different. Okay.
This Sunday, day after tomorrow.
This Sunday. Oh, okay. So every Sunday the station will be different, or Sunday and Saturday?
Yeah, that's right. Yes, there are only 2 modules left now for that batch anyway. So labor ward and delivery suite. Sorry, delivery management and labor management. Sunday scenarios will be different. Yes.
But for Saturday batch, Mom, from the next week, the same station for us, and or will be different?
No, they will be same.
The same until they finish.
Yeah.
Okay.
Ma'am, can you please show the slides of reflective learning for a few seconds? It will come in the recording.
Yeah, sure.
Okay. Don't forget, please, to send us the PDF or PowerPoint today, please.
Send, sorry, what?
Please, Mom, can you post the file for today in the group?
Yeah.
Okay, thank you.
Well, you will have the recording. So in the recording, you will have the file. Yeah.
No. The file itself.
Oh, hala, don't ask me too much. Then I will end up taking the pictures of these to send you. So once you have this recording, which will be tomorrow, you can take this screen. Yeah. I'm just going to put all these, but I have, for some reason, my screen got split. Let me sort this out first. Okay. Right. Okay. So this was the one we have done. So you can take the screenshots now, or you can take when you get the, and this one was the questions if it comes as a, so this is bullying and harassment, right?
So this is how the examiner will ask you the questions if it comes to structure discussion.
Doctor, what will be in next session?
We just discussed it 3 times already, darling. So tomorrow is labor ward management. Next Saturday will be delivery management, and Sunday will be same labor management and delivery management. On 14th and 15th of March, 14th of March, we will have structure discussions. On 15th of March, we will have some more like these reflection and these few of these bridging prophylaxis and all these scenarios which are left, these important ones.
So structure discussion will be from all modules, like from all the modules, it will be mixed. That was my question actually.
Topics who have been coming like SLA and you know, these recalls, structure discussions of PPH management, placenta, previa, I think there was. So you need to send me the scenarios, like chief sector discussions, what have been the previous recalls. Okay. Okay. So this is about
Thank you.
Hello.
Okay, this is about reflection then. Yeah.
Ma'am, can we do one station on an angry patient or angry partner?
So who is this? Who is talking? Sorry, tell me your names first.
Hello, ma'am. I'm Deepthi, ma'am.
Deepthi, we did angry father station in surgical skills. Father of that girl of TOP. So you will apply the same template for the angry husband as well. Yeah, but I will see if we can add that just briefly to go over the other scenario where that person has hysterectomy after uterine artery embolization and the partner is angry. Okay. Thank you. You can take the pictures of this reflection thing if you want.
Yes.
So this is the next slide.
Dr. Safia, previous slide, please. Dr. Safia, previous slide, please.
Previous one, please.
Okay. I'm starting this from you can see which one you have already taken, right? So that was previous. This is the first slide and reflection station. Just to give you some background, what reflection exactly means and why we do it. So these 4 points you must keep in mind clearly, because the scenario we have will be, we will be putting into this template. And this as well. So this will be expected from that trainee to address, and you can ask, you will be asking like this. And this is the scenario. Well, you can take this picture as well. This one is just a teenage pregnancy. I know I have discussed teenage pregnancy management in few, but I just wanted to briefly go over that again, just summary. We will do that as well, so that you guys know exactly when there is teenage pregnancy, what you need to keep in mind. Okay, that's all for today then. I will be sending, as I said, the recording audio on that group of bullying and this one reflection. And then, yeah, so I'll see you, whoever will be in the session tomorrow. Okay, goodbye and good night.
Good night, Dr. Safia.
Good night, Dr. Safia. Thank you very much.
Night.